requirements. I think I know this was discussed in USA as well in the past, but I think SOGO is the best platform for doing this. My memories go back in 1986 when I had the first occasion to attend this SEO seminar, and this was a similar discussion that happened then. John Donohue was the president, and they were also discussing who to become a uro-oncologist, what should be the credentials, and what should be the course curriculum, and who should be, and what should he get out of that. Of course, that there were some discussions, points here and there, but ultimately it took some time for them to really go through that, and now it's established. Now coming to India, for that matter, as you see, the urological oncology cases are increasing. Our oncology infrastructure is increasing. You know, you've got 56 oncology centers which are taking care. Plus, there are several corporate hospitals, Center of National Excellences, who are now dedicating themselves into oncology cares, as well as in which case we will require many more people to join these urologic oncology part. And obviously, there is a need for that. So therefore, we will require a dedicated program to start this. Of course, the nitty-gritties, I don't want to get into that. We'll get into that as the discussion goes on. But there is no denying fact that urologic oncologists are required across the country, length and breadth. And it's time for us to understand what should be the correct curriculum, correct pathway for them, and what are we going to offer them. This is not only in terms of metropolis, tier 1 cities, tier 2 cities, and tier 3 cities as well, because the number of cases, oncology cases, are going up very high, rapidly for that matter. So I think this is very, and when we discussed this in SOGO, and I must say that we decided that Dr. Raghavan would be the right man to, because he has got experience of having practiced urological oncology for several years in India and then abroad, and he was the man who can really put this program in perspective and get us the ultimate discussion going to the end. My request to all the panelists is feel free, because it's an interactive session. At the same time, the point should be crisp and it should be dedicated. And of course, as we go on, we will continue to get updated and so. And this may be the first session to start with. There is nothing to feel bad about that. And with these remarks, I would request now Dr. Raghavan to continue. Thank you very much.
Many thanks, President Sir. Thank you so much for your kind words. It's a pleasure and honor to be here amongst all the seniors. Can I request President-elect Sudhir Raval Sir to share a few words?
Yeah, thank you, Raghavan. If you see the background, I am a uro-oncologist, not by choice. I am by serendipity. And this happened to me because I was searching some place in Delhi, and I landed up in Rajiv Gandhi Cancer Hospital, and I never wanted to become a cancer surgeon. Then I saw the country, and in country you can only see the Tata at that time, and Dr. Kulkarni is, I think, country's first MCH uro-oncologist, who actually was there in Vellore when I was under training for Reg Hall meeting.
Yes.
So I never thought that I'll end up with a uro-oncologist, but when I joined this place, I realized that's the best place probably for me because of the challenging surgery, especially radical prostatectomy at that time, and hardly very few people were doing cystectomies and other surgery. Mainly it was in the hands of few surgical oncologists, in at least in North. I'll not say in TMH and all, where the branch was very developed because of Dr. Murli Kamath and Dr. Kulkarni. And things, they shaped up slowly in Rajiv Gandhi. And with the time, more and more young urologists, they opted for uro-oncology. And as you see now also in this meeting, we have around 20 uro-oncologists who are practicing mainly urological oncology in their respective hospitals. That may be multi-specialty hospital, like Gagan Gautam is there, and then Yuvraj also made his place, and even Raghu and Gainil were with me in the beginning, and then they created a huge space for themselves in South. And later on, Raghavan and Sanjay and everybody has joined. And this crowd is increasing every month or every year. I can see that young urologists. Right now, I have got 6-7 urologists who was working with me in uro-oncology, and they are all interested to develop their career in uro-oncology. So that's a need of our to have a this session, which Raghavan has actually is his brainchild, who he said we should have this session and we should be having a fellowship in uro-oncology, for which I asked him to call Dr. Nitin, Dr. Ajay Kumar and Rajiv Kumar, who are actually in National Board of Examination, NBE board, National Board in as a urologist, they look after the urological training and other things in the National Board. With that, I'll say that hopefully the things will shape up today. We will be able to convince our these concerned people to at least start some fellowship in through NB, so that in future we can really develop this branch in the country. Right now we have started SOGO, which is not an, we could not do any physical training meeting because of the COVID and all, but at least it is shaping up with time, and hopefully the things they will go, and we probably will develop like SEO in America. Thank you. Raghavan.
Sir, thank you so much. Very kind words and very thoughtful words as well, because the branch is expanding and exploding in front of us. And with that, poses a single question. Do we need this branch? What is this branch about? Why do we need it? Who are the one who can get trained? So who is better than Sanjay to tell us all about this? My close friend, Sanjay, please come on stage. Sanjay is an experienced uro-oncologist, my colleague, my mentor, my friend, worked together for more than 15 years, no, nearly 20. He was the head of the cancer lead in Leeds, and he was the head of the cancer network as well, and has published well on this thing. So Sanjay, please come along.
Thank you very much, Raghavan and seniors, and very grateful for this opportunity. It was an open topic, so I have made something out of it. So hopefully it's of some use. So I'm just trying to address those questions: what, why, and whom. Disclaimer, I worked in UK for 19 years, so I am biased towards European and UK health system. And I have got some experience of managing cancer network. So I'm going to try to see whether we can do something similar in India. What is the background? Where are we now currently? So when we look at the best healthcare systems in the world, if you see all of these, the main ones, the ones that come out are in Europe and of course Canada and then New Zealand. So just try to remember the flags. So they are in and around Europe, and these are the top 10 countries with the best healthcare system. And what they have used is they have looked at the quality of care, access, efficiency, equity, and the cost efficient nature of the health system. And when we look at whatever the best ones were, if you see them, they are on this left side. So whenever the government pays for the healthcare, it seems to be a much more efficient way of providing healthcare compared to individuals paying. So this is what it is showing is Netherlands. The government spends 87% of every $100 that is spent on health in Netherlands. Norway, it's the same. Sweden, the Nordic countries are the same. Whereas when you look at US, it seems to be here. And if you look at India, India is only $30 out of every $100 that is spent. It is from the Indian government. And what does India rank very high in? It is about out-of-pocket expenditure for the patients. They spend quite a lot. So the highest rank in the world for out-of-pocket expenditure is in India. Every quality healthcare has to provide an effective care, a safe care, and more so about a coordinated care. We do provide, let's say that they go to Tata Memorial Hospital, they get the best care that is possible in India and probably one of the best care that is possible in the world. But when they go to some other oncology center, they might not get that good a care. So we do not seem to have a coordinated care wherein we can ensure that the patient gets a good quality. I'm just going, somebody is hoovering, I'm just going to stop that. Sorry, somebody spilled water and they're trying to hoover it. So the government, the BJP government formed the National Health Policy of 2017. And if you look at the objectives of it, we currently in 2017 was spending 1.2%. And though we are doubling it, we are planning to go up to 2.5%. And what, if you look at the countries that are higher up in the better healthcare, you see UK 8%, France 11%, US 17%. Probably the most cost inefficient health system in the world is the US health system. And the reason why we have got these sort of numbers is because of the discrepancy in the amount of money we are spending. So orange is for India and the purple is for UK. So if you look at the prostate cancer mortality from the Globocon 2020 data, 48, so half mortality with respect to prostate cancer. And mind you, this is only from the cancer registries in India. Cancer registries are mainly there in teaching hospitals or cancer centers. We are not talking of what is happening across India. So we are only talking of people who have sought treatment in cancer centers in India. In them, half mortality or double the mortality of what we see in UK. And the most painful for me is this, which is the mortality in testicular cancer, a curable cancer. The mortality in UK is 2.44%. Currently for 2020, the mortality in India for testicular cancer is 26.8, which is, I think we are letting down a lot of young people in India. So that is where the background is. So what is uro-oncology? I'm trying to teach the learned people, so I can skip this part of it. It is a subspecialty, deals with the uro-oncology element of it. Who comprises the team? It is not just the doctor. It is not the individual who's providing. We need a medical oncologist, radiation oncologist, pathologist, radiologist. We need the dedicated secretarial staff, nursing staff, data managers, and most importantly in India, a supportive hospital, because we don't tend to find that very often. Why do we need it? Because uro-oncology is a bit strange, because we know that in prostate cancer, there is a lot more of overtreatment. If you were looking at small renal masses as well, there is a lot of overtreatment. Then the second element, there is a balance between cancer cure and functional recovery of the patient. I might do the best radical prostatectomy, but if I don't join it up properly, patient would be leaking urine. He's cured of his cancer, but it doesn't have any quality of life to live or worth living. And there is always a balance between whether we can irradiate it, give the medical oncology or the surgical oncology. So that's the reason why we need a uro-oncology as a subspecialty. Do we need it separately? Because it is much more nuanced. Like if somebody has got a colorectal cancer, I don't think there is anything to discuss there. That part of it needs to be removed. There isn't any quality of life impact because that they can be joined up. Whereas in uro-oncology, each treatment is associated with an impact on the quality of life. That's the reason we need to be having it as a separately. And the knowledge expansion is just immense. Every day there is something new that is coming up. So you can't keep up unless you were concentrating on uro-oncology. And that's the reason why we need it separately. Is it needed in India? Because uro-oncology as subspecialty, I was there when the transition was there in UK at the beginning of the millennia. Now, is it needed in India? And definitely yes. I've specifically said Indian continent, and it's staggering when you see the discrepancies that are there in India. This is a very, very interesting one. So if you see 1911 Kerala to 2011 Kerala. So if you see 1911, a century ago, there were a lot of younger patients. So this is the age demographics of Kerala population in 1911 and 2011. You see that there were lots of this blue color, 1911, there were lots of younger people. Whereas now this is more of a developed country. Kerala is more like a developed country wherein the age distribution seems to be going upwards, middle age and going towards elderly. Now, when we look at Uttar Pradesh 2011 and Kerala 2011, look at this blue color and compare it with this blue color. So Uttar Pradesh demographics currently are the demographics of Kerala in 1911. So within the same country, we seem to be having discrepancy in the demographics, almost like east and west of a continent. So that's the reason I said Indian continent, just because Kerala and Uttar Pradesh might be in different parts of the world, not in the same country. And what we see is, if you see here, when you look at southern India, stomach, colorectal, and prostate are the commonest cancers. Western India, lung, mouth, and prostate. Northern, tongue, larynx. So that's the reason why there seems to be a difference in the cancers in different parts of India. Again, almost like a continent. They don't behave like a single country. One thing to note is, at least in the 3 out of the 4 zones, the third commonest cancer, this is 2008 to 2012, is prostate cancer. This is based on the cancer registry. So prostate cancer does seem to be going upwards. Okay. And within India, there is a huge discrepancy. That's why we need subspecialization in India. And what we are seeing is from deaths from communicable disease. So if you see there, again, Kerala, 1990 to 2016, the deaths from communicable diseases they become almost stabilized. Whereas Uttar Pradesh, you see that almost it has become half. The deaths from communicable diseases, this is deaths from communicable diseases, has half. But what we are seeing is, both in Uttar Pradesh, especially in Kerala, we are seeing more deaths from cancer. This is what was seen in industrialized population. This is what we are seeing now in India. So that is the reason why we need more care towards cancer delivery in India. And the best one to exemplify this is this one. This is the Globocon data for India in 2020. If anybody wasn't aware, the commonest cancer in India is breast cancer, not cervical cancer, not oral cancer. Breast cancer only happens in female, but the incidence is so high that it covers for both men and women. So the commonest cancer taking both sexes as of 2020 in India is breast cancer. Breast cancer is not related to infection. We used to say that cervical cancer is related to infections or promiscuity or tobacco. Now we are going into the cohort wherein these are lifestyle things. That's why we are seeing the change in the demographic, as well as the change in the cancer pattern that we are watching in India. Is there any expected need? Is there going to be more need for oncologists? This is a bit old. This is estimates from 2015. So if you see, as of 2015, they had 350 linear accelerators. In 5 years, it was supposed to be double. And if there are no financial constraints, the demand is supposed to be even double that. And the same with respect to the surgical oncologists. This is surgical, all included. There was supposed to be 500 in 2015. The need was to be 2,000 by 2020 and 2,500 if there wasn't any financial constraint. So we don't need to be worried about, okay, am I going to get trained and there won't be a market? No, there is still going to be a dearth of specialized people in India come whatever the year. What we need is, we need leaders to take on leadership loads so that the cancer teams can progress and deliver the care. What we need is subspecialization, standardization, and the most important, coordination and centralization. The reason why we need centralization is, we know anybody who does more of it, even if I was massaging somebody's back, if I do 10 massages a day, I'm much better than somebody who massages somebody's back once a year. And the same will be shown with respect to any surgery. This is data from Germany, one of the most streamlined health systems in the world. What we see is, even aortic valve replacement, the more you do, if you do 22 to 42, more than 42, the mortality is lower. The mortality is lower when you do bypass graft. The mortality is lower when you do even emergency abdominal aortic aneurysm repair, more closer to heart, cystectomy. The more you do, the less is the mortality. Esophagectomy. I don't need to tell cancer surgeons that the more you do, the better you get at it. But if you see the unit volume, so it is the same surgeon who is doing probably one cystectomy every 3 to 4 months. Even that is not good enough. But if he was working in a smaller center, which does less number, his mortality is almost 3 times what it is compared to a center that does more. So higher volume centers, higher volume surgeons is what we need. And that we are only going to get by doing centralization. Doesn't need to be government authorized centralization. We should be willing to refer it to people who are better skilled compared to just doing everything ourselves. Because of the learning curve, we are all aware that there is a learning curve to everything. Driving everything, there is a learning curve. And if you look at the learning curve for this is the learning curve for laparoscopic radical prostatectomy. This blue line is 250 cases. You might spend all your lifetime, still not do 250. Still you're learning. Do you think you're going to learn by doing about 10 laparoscopic prostate? Patients are going to suffer. And the same with respect to open. If you see the learning curve, recurrence-free probability, if somebody has done 1,000, he's much better compared to somebody who has done 250 to 1,000. So the more you do, the better you get at it. You can't just say that I've done 15, I've mastered it. You haven't. You are still learning. The more you do, the better you get at it. The key message is we do some way need to find a way of organizing it and centralizing it. That would improve our outcomes. Whom will be doing it? Who can do it? I always believe that though in India we feel that we choose a specialty, I feel that the specialty chooses you. When I was in India in 97, I wanted to do orthopedics. If I didn't want to do orthopedics, I said I will do pediatrics. Now I think, how can you be any more stupid? The skill set that you need to being an orthopedic surgeon, to being a pediatrician is totally opposite, but that's what I wanted to do. So when I went to England and I was doing general surgery, I said, okay, what should I do? I asked Simon Stubington, who was one of the consultants in Crew, and he said, okay, go into the surgeon's room and see the surgeon who is throwing a tantrum, who is being bossy, who shouts at everybody. Generally, he's an orthopedic surgeon. See the surgeon who is very tense, always looking at his watch, who keeps on going into the theater and keeps coming out, who can't be comfortable. Generally, is a cardiothoracic surgeon. A general surgeon is somebody who is sleeping there on the couch because he had a very busy last night opening somebody's acute abdomen. A plastic surgeon who will always be discussing about where he went for his last holiday and where he's going to go for next holiday, which is the VIP patient he has operated on. The person who is going to talk to you as an equal, who is interested in new technology, who is willing to do new things, will be either a urologist or an ENT surgeon. And whenever you ask any of the UK consultants, they always say that I considered ENT, but I thought I chose urology, because actually the specialties are very close to one another. There is increased use of technology in both. Both of us love to operate through narrow holes. Third one is there is a functional element to both ENT oncology as well as uro-oncology. Though we operate at two ends, they are quite close to one another. So that's the reason why I became a urologist. Once I chose urology, then I thought, should I become endourologist? You've all done it. I did it for the first 5 years and I thought I can't be breaking the stones. Either I didn't have the patience, I just said, I need to do something else. Reconstruction, again, I tried it and I thought, I do not have the skill set to be looking at such fine sort of a work. Then I chose uro-oncology because I thought I had a knowledge basis, but I went and did a research degree, MD, so that I can gain more knowledge. But I had the keenness to keep on regularly updating myself. Surgical skills, you need both the endoscopic, laparoscopic, open, and robotic. But the most important one is the aptitude and the communication skills. Aptitude to work with your colleagues, whom you treat as equal. He might be a radiation oncologist, medical oncologist, a psychotherapist, a physiotherapist, and having the communication skills and the empathy to communicate to patients. If you think you have got these competencies, you are a very good uro-oncologist, and you can always train up to be a uro-oncologist. The future is bright because the future is you. Thank you very much.
Thank you so much, Sanjay. As ever, a very, very, very nice talk. You have laid the basis for the whole webinar today. So that the last slide, last but one slide, was the best slide. What makes one a very good uro-oncologist, and why does the specialty chooses you? If you have the attitude for those characteristics. That's what makes you a uro-oncologist. Thank you so much, Sanjay. Really appreciate your time.
Thank
Any
you.
questions from the other faculty for Sanjay? If not, we move to the next, which is Ginil. I invite Ginil, Professor Ginil Kumar, my very good friend, to talk to us as why did I become a uro-oncologist and what is that for me? So, Ginil, stage is for you now.
Am I audible?
Yes,
sir.
Ginil.
Hello.
Yes.
Yeah. Hi. Thank you, Raghavan, for selecting me for this topic. Actually, I have got my colleagues to discuss with. Before I start, this is something like a panel discussion just to share the experience of different people who has established in uro-oncology in India, the generation who is coming up in the uro-oncology, why they selected, how they selected, and what was their experience during fellowship and after that. This is what we are going to share with you in this panel discussion. Before I grill my panelists, I would like to say how I became a uro-oncologist. Actually, 20 years back when I had my MCH, I could see only one person in the entire country who was doing good work. That was Jagadish Kulkarni sir, and I wanted to meet him. So, but he was considered to be the godfather in uro-oncology, and it was very difficult to meet him. I was just following. One thing I felt was in my state, what Sanjay told is very much improved in all the health statistics in Kerala. Almost 100% of the individual were having orchiectomy for CA prostate. And that is what I actually was embarrassed during my MCH. And in my unit, in my hospital also, the standard of care for CA prostate was orchiectomy. So I felt that somehow I have to learn radical prostatectomy and I have to just divert to oncology where the treatment was not at par with the Western world or even in good centers in India. So I came out, I joined Amrita. Again, I saw the same thing is happening. So I asked my boss, Dr. Sanjay, but I want to go and get trained in uro-oncology. That's my passion. He told me, I got one friend who is my junior working in Delhi. Go and meet him. So I met him. That was Dr. Ravan. So I stayed there for almost for 3-4 weeks. During that time, I saw the importance of getting volume, then importance of having a quality work. On last day, I got a call from one person, that was Raghunath. Hey, what should I do? I finished my MCA DNP. I told you, come and join with Ravan. So that was how we two started. So coming back, the situation has changed in 20 years. I went to Amrita, told my director, I want to start uro-oncology. The next thing he asked, oh, if you are leaving all the other urology things, who is going to pay you for that? So I was totally embarrassed. So he told that with uro-oncology, you cannot survive. So I just gradually built the uro-oncology volume. In 2013, I decided to completely divert, and we decided to plan to have a fellowship program. Then I got the robot. So actually, robot helped me to some extent to just speed up the program. But I felt that it should be a part of the uro-oncology program. It should not be. So I just diverted entirely into training uro-oncology, and that was how I jumped into. So I'll just share the experience of different people has went into uro-oncology. First, I would like to, my panelists will be there, Srivalsa, Venkat, Kunal. Kunal is there. Yeah. So I'll just start with Srivalsa. Srivalsa, you know that we have almost 20 years we were in uro-oncology, and do you consider that at present, if somebody is asking you to divert to uro-oncology, is the right time, because almost 20 years you are working and you know the current situation. will you advise a relative to go to uro-oncology at present? Because I'll say I'll thank Ashwin for this excellent article in the Journal of Urology about the training program in uro-oncology, subspecialization. And he had these 2 slides. One, majority of the people consider subspecialization. And second, among the subspecialization, he found that everybody is actually directed towards minimally invasive surgery and then towards uro-oncology more than other wings. And endourology also comes almost equal to uro-oncology. So Srivatsa, will you advise one of your relatives to go for uro-oncology at present scenario?
Good evening all. Thanks for the question. I think Dr. Sanjay Adla has already very vividly explained the characteristics of being a subspecialist, not necessarily uro-oncologist. So if there was somebody who was willing to pursue the career with the right aptitude, I think uro-oncology is probably one of the best or probably the most evolving subspecialties in urology, or for that matter, even in oncology. So I would very strongly recommend if somebody is keenly interested in uro-oncology.
So you want the person to be keenly interested in the uro-oncology, considering different aspects, the perspective of uro-oncology. Otherwise, if he is not considering those aspects because of the charm of any treatment, he should not jump into. That is what you mean, is it? There should be a passion.
Yeah, there should be a passion for the subject, for the branch as such.
Okay.
So I think, it's a digression, but I can say that of late we have seen that there is some amount of dilution in the objective with the charm of the robotics. So I think like all of you have already mentioned, uro-oncology is a much wider and a much broader specialty with more intricate commitment required rather than just the platform of surgery. So we'll have to make sure that if some candidate is really keen on pursuing uro-oncology, it is for the sake of uro-oncology and not for the the way we do the surgeries.
So Vivek Venkataraman is there?
Yes, sir.
Vivek, yeah, Vivek. The next question is from the same publication. You see that people are more interested to this technique of minimally invasive surgery, whether it's robotic or laparoscopy, rather than a specialty like uro-oncology or endourology. What is your opinion about that? Can you consider these two are at par, or should we go towards a specialty or towards the technique?
So I think Srivatsa also very eloquently said that it's the passion and the interest for uro-oncology that is what should be driving it. So even when I came into MBBS, it was always MBBS or engineering. My interest was MBBS and medicine. So that's why I came into medicine. Same way, my interest was always oncology. That's why I chose uro-oncology. It was not particularly for any technique like what everyone has mentioned. And in fact, in one of my US fellowship interviews, one of the program directors, right out, he came and asked me, are you here to learn robotics or are you here to learn oncology? So only when I told him, sir, I want to learn oncology, did the interview even go to the next step. So, it was very clear that even from that time, this was 2014-15, that people were just thinking that this is only a robotics fellowship. So he said, if you want to learn robotics, you can apply for many of the minimally invasive fellowships. There they include endourology, laparoscopy, and robotics as part of the training. But it's only whether you have the passion and the interest in oncology that you should be coming to our fellowship. So that is what it was already, being thought of in US at that time. So I don't consider that they would be equivalent, but I think it's a misconception that people have that, uro-oncology is only for robotics.
Great, Vic, because I also agree with you. Srivatsa, any more comments you want to make on this one? I think that part is very clear. If you are actually having passion about the subject, you go ahead with a specialty. The flexible ureteroscope or robotics, that will change. Tomorrow there will be something else. But if you want to treat the patient, a disease, you select that subject. That is the most important thing we have to decide before we jump into any subspecialty.
Absolutely, sir.
Indranil, hi. Indranil, are you here? Yeah, Indrail.
Yeah, I'm here.
Okay.
Yeah.
Yeah, Indrail. I know that you just landed back from US. What was your actual factor because of which we already just discussed, don't think about that. And why you selected uro-oncology as a topic, and when is it because of the passion or a glamour of it, or a robotic surgery, or somebody just told you?
Not the last one. Just somebody
not
told me,
okay.
My friend told, not the last one, for sure.
Sure.
But yeah, it's a combination of all the factors. As
Okay.
Dr. Vivek already mentioned, or Sanjay Adda already covered it very nicely. There's unmet need in my place, that is West Bengal. There was unmet need for a subspecialty uro-oncology that drives the passion to develop a new program. That's what I'm trying to do it here. Yes, glamour is there because mostly you will get access to robots, but as Dr. Srivas has already mentioned, it's not only about robots, it's also about learning the subject. And during residency, it's mainly about endourology and laparoscopy. So if you want to focus on a subspecialty, uro-oncology, one needs to get a fellowship done. Otherwise, the complete learning is never there.
Yeah.
So that was the reason I did the uro-onco fellowship.
Thank you. I can find that when you decide about a fellowship, first thought will be whether we should go to the West. The paper also, same paper from Ashwin, also tells us that majority would like to go to West for a fellowship if they want to. So Kunal has his fellowship here. Ashwin actually had from here and jumped to UK. So what do you think, Kunal? Are you happy about the fellowship program here, or again, you feel that it is incomplete?
Sir, thank you everyone. Thank you for the opportunity. As I have just finished my fellowship 7-8 months back, and I've just maybe the youngest among the year who have just finished my fellowship. I did my 2-year fellowship from Tata Memorial, and it was a complete satisfying experience. As we all know, Tata is the apex cancer institute, and as we say, it was a complete exposure of open lab, robotic, everything. To be honest, I'm very not sure whether how is the fellowship outside the India, because I've never been to. Maybe Ashwin can comment because he has been. We both were together in Tata, and then he went to UK to get it trained. So I was completely satisfied. Whatever I learned in 2 years, thanks to Dr. Bakshi, Dr. Gagan Prakash, it was a very nice experience for me.
Ashwin, why did you go to UK, or do you feel that it will give you more experience, or what was the real thing behind that to go to UK after having a fellowship from here?
So most important thing, sir, is probably I would say for a new beginner, an observership before entering into a fellowship, it in fact is a most important pillar, because the center where you would want to work in as a fellow, you should go and observe that particular center yourself. Or say, suppose in this all publication came out of agitation in my mind that why I'm not able to take a decision at the end of my residency to subspecialize. Is there any lacunae in the training system? Is there any lacunae in the training for 3 years? Instead of having a training in 3 years, I'm not able to take a decision to be a uro-oncologist at the end of the tenure. And then this particular publication came up as a background of that. We did analyze it from the people as in third-year residents. So many people in residency programs do not have an opportunity to observe a high volume center, for example, uro-oncology, where they would want to subspecialize. So most important thing is observership in a dedicated center, that I would definitely say. Considering the fellowships, comparing fellowships in India and West, technical skills wise, I don't think that there is any discrepancies. There will be all equal, obviously. The learning opportunities or learning or training patterns are little different. I'm very sure Vivek will also agree with me on the subsequent slides. So probably the learning pattern is different. You have better opportunities for research, better opportunities for funding. US fellowships, obviously you will have 1 year of dedicated research majority of the times during the fellowships, and followed by 1 year of 1 or 2 years of clinical work. UK more of it is a mixture of clinical and an academic research, not the molecular research, but you have a systematic plan for all the fellows. For example, giving an example of center from UK where I got trained, 5 different people were doing organ specific work. One person was doing radical nephrectomy, one person was doing cystectomies, another 2 people for prostates, 1 person for partial nephrectomy. So it gives you a different perspective. It gives an opportunity to learn from 5 different people and 5 different techniques, and that particular person is going to take forward your particular step of particular procedure in the subsequent manner. So no comparison between 2 for different as an Indian and Western fellowships for work per se. We are obviously at par excellence with the Western countries. A little bit about better research opportunities and a little bit about better opportunities once you come back as well. That also I should admit, once you have a fellowship training from you from the West, you have a little better opportunities opening up in hospitals in India. That is also one small perspective.
The good thing about this thing is the person who has had that experience, they'll be able to train the next generation in a better way than how we could. Actually, it is more organized, research oriented. All these things has to be there in the fellowship program. And I think that gradually we in India also is sensing the need of having this structured training, and even this program is a step towards that. So Ashwin, thank you for that great answer. Yeah. Yeah, the same thing I was wanted to have from Ashwin. Ashwin already told about from Vivek. Do you agree with Ashwin? Do you want to add anything on this one? Because the same thing Ashwin was discussing.
Yes, sure. Actually, definitely in terms of research, even though I was trained at Vellore, I had a lot of opportunity to do research. We even published a trial during my MCH. So I was already, exposed to that level of research even during my residency. But of course, when you go to US, you have a lot more funding, a lot more support. You get access to the national databases very easily. You can think of questions. We had 6 or 7 uro-oncologists. We were discussing different techniques, different questions to answer using these databases. So the opportunities for research are much more. And I was lucky enough that Dr. Parekh even involved me with the RAZOR trial, so something which is a multi-center, world's first phase 3 trial on robotics. So which you only read about probably when you are during your MCH or during your fellowships. So I could be a part of that. So that was like an unparalleled learning experience to understand. It's $1 million grant from the National Cancer Institute, where the money goes, how do you recruit patients, how do you get everything analyzed centrally, how to discuss everything with the statisticians. So it was really something which took my understanding of research to a different level. So that is something which I think did give a huge boost in my understanding of the disease. In terms of training, and at that time, robotics was not so common in India. Now I think almost every big city has 2 or 3 robots. But during our MCH, we weren't exposed at all. So that was also one of the attractions. But when I came back, I saw that PSMA is being used here left and right, where we never had PSMA in the US at all. So, so there is a give and take. Nowadays, the technology transfer from West to East is very fast. In fact, the FDA delays things in the US for much longer as compared to other countries. So PSMA was just approved 6 months ago. Till then, it was only a research molecule. So till now, here we have so much more experience. I had never been exposed to that during my training in US. So there are pros and cons of both techniques. But one thing which I do feel is the soft skills that you learn about dealing with communication with the patients, communication with your colleagues, a multidisciplinary meeting, a centralized system. The volume in the US is because people in the community don't want to operate a cystectomy. They don't want to operate a prostatectomy. They refer everything to a tertiary center or a university center. So we were doing 4 or 5 cases a day. So, that kind of volume is generated, and that kind of, like Dr. Adla pointed out, that it's the volume and the center's volume that leads to good results. So that's where, the centralization really helped in terms of getting a volume as a fellow in terms of hands-on experience. So definitely these were some of the things that were of great benefit to me during my training.
So I'll ask you a teasing question. The thing is, you are in Vellore and you had gone to Miami.
Right, sir.
If I ask my resident or fellow, you come with me to a molecular research lab or have a paper, sir, I'll come tomorrow. And if I am asking to come assist me a surgery, yeah, they are on next second, they are with me. So that attitude, why it is like that here in India?
So because,
you think that it's not rewarded?
No, it's not rewarded, and we don't understand the long-term benefit of doing the basic research. So what looks like something which is going nowhere, which is very boring, which you're breaking your head and nothing is working, what we don't take a long-term perspective of that. Everything, especially when you're young, you're a resident, you want to just finish things and go ahead. But the importance of a long-term thinking of where that can ultimately lead you in 10 years, when you are an assistant professor, when you are a professor, that's something which is probably lacking. So that basic level of research and the quality of that research, because we have no funding, is also difficult to do. So probably a combination of those factors is what is people are more interested in getting to practice. So that's the ultimate goal. So an academic bent of mind is not so common among Indian residents, that's for sure.
Ashwin?
So I would like to add quick one thing. It's not that we can't do research in India as well. Clinical research I'm talking about, not molecular. With Gagan sir, I published about 12 papers in one particular year. That one particular fellowship gave me a very prominent boost in all aspects, including academic, including clinical activities to learn about the robot and the academic activities. And it helps definitely in counseling to my own patients. When I give my own paper to the patient, it creates a different impact, honestly speaking. Or say I gave a data on transperineal prostate biopsy versus transrectal biopsy, which has been, I'm a first author for that in BJU, and that is going to be accommodated in EAU guidelines next year. We have got a confirmation on that. When I give it to the patient, it will make a different impact. So it's not that it's not relevant at all. It is relevant in all perspectives.
Okay, so that is one thing I feel that is what is lacking in our population that has to be changed. The attitude change is necessary for us to improve, both among the mentors like us and among the residents. So we were discussing about the attitudes. You will be seeing a lot of, you are exposed to residency program, fellowship program, because you are a fellowship director. And this is again a Canadian urology journal showing that the residents, what they expect from the fellowship program, they want to improve the technical skill, but about the clinical for research, even the Western people are not much concerned. This is from Canadian paper. They are more concerned, the residents are more concerned about improving the skill. Or actually, should we impose the research quality or through the mentorship? So also, what is your opinion about what should be the quality of the residents, and what you expect to deliver in the residency program, and what should they expect from you?
Yes, it's a long question. I'll just break it into small parts and respond. One thing is, what is the quality the fellow should have? Like Dr. Sanjay Adla said right up front, I think he should have the right aptitude. This was also very evidently discussed by Vivek, where he said his mentor asked him, what do you want to be? So the idea is that the fellow should have an aptitude for uro-oncology, managing oncological problems in urology as a whole, not just doing the surgeries of radical prostatectomy, cystectomy, or hello.
Yeah.
Also,
we lost Srivatsa in between.
Yeah.
Hello.
Now we can hear you. So
yes. So he should have a comprehensive aptitude of managing all kinds of malignancies and dealing with even advanced malignancies and handling terminally ill patients. So this requires a lot of courage. So the aptitude should be right. The drive to work hard should be there. he should be compassionate to patients, because oncology is all about patients who are either concerned or sick or apprehensive. So there should be, being compassionate is probably one of the key elements that I will be looking at a fellow who would want to, train. And he should have some, I think even Dr. Raghunath will agree on this, right from beginning we have been pursuing, trying to look out for fellows who have an inclination for research work. So right now, we are lucky to have a couple of fellows who are extremely interested in research work, and they have chosen doing basic science. One fellow is doing a basic science work. The other one is pursuing a translational research activity. The challenge is the overwhelming clinical burden. So they all want to train to become good surgeons first, but with the kind of overwhelming work that a program would have, there is, I think, very limited time for and scope for doing research activity. Also, the fact that not all centers uniformly have access to research facilities. So I think it's a very complex situation here. The fellow should have all these aptitudes, but at the same time, the program should also be in a position to provide these platforms for the fellows to utilize.
Yeah, thank you. The paper from Monish Sharon, after he went from here to US, also tells about the difference in the teaching schedule, the need for the structured training program. So a few things. This is about the residency program, but I think fellowship program also, this is very important. So Kunal, do you think that what should be the ideal duration? Because why I am asking you is, when I started my fellowship program, since it was 2 years, 3 years, I didn't get any fellow. Only the people wanted to just come for 1 year and go. So what is your feeling about the optimal duration of the fellowship after finishing?
So according to me, at least what I have, at least 2 years post MCH, one should be there in the uro-oncology, and that doing a training mode, not in associate consultant or a decision making mode, just under the guidance of someone. Because I believe that at least for first year, because during an MCH or DNB training, you are just very superficially exposed to what is uro-oncology. But the detailed nuances, like we said, Sanjay sir also said, with the cancer outcome plus the functional outcome, which should get a balance in a bridge, those detailed nuances or tailor-made treatments, which comes to know, you try to understand in first year of your fellowship, and then in the second year you gain a little more confidence, and then you try to make few decisions, attend tumor boards, make your presentations, say your suggestions, whether they are approved or not approved. So I feel definitely a 2 year, minimum 2 years is definitely a need post MCH. Even if not, even more is better, but obviously you cannot go on, but at least 2 years.
So Ashwin, you had experienced both sides of the globe. And how should be the curriculum of fellowship training, and what do you mean by structured training program?
So the information on this, there is a good information bulletin by Society of Urological Oncology (SUO) on structured fellowship programs. That will be a good amalgamation of good hands-on training in terms of all uro-oncological aspects. For high-end surgeries, say IVC thrombectomies or say neobladders, you may not expect to have done it at the time of fellowship completely, but you should be exposed well to these particular procedures, and all the run-of-the-mill procedures should be done in adequate numbers for you to achieve some proficiency. There will be a learning curve which you have to overcome on your own after you finish your fellowship. You can't expect to become, as in tomorrow after I finish my fellowship, I can't be Dr. Manal Kumar. So it takes time for me. It will take another 5 years for me to be proficient to that level. So that one has to understand as a fellow as well. So it has to be well balanced from mentor side as well as from fellow side. Fellow's expectation should be kind of moderate, and mentor's attitude would be to kind of balance it out with the fellow to give him as much as possible work as feasible in terms of academics, in terms of clinical work, in terms of possible research work. And most important thing is subsequent fellowship opportunities, post-fellowship opportunities should also be a part of the surgical training pathway, because that is also one important factor. You can't leave the hand of a fellow after completing the fellowship. The mentor is supposed to kind of guide the fellow throughout the journey, and which I'm grateful for my all 5 previous mentors. So that is one thing. Curriculum, there will not be any structured curriculum, to be honest, but it has to be tailored based on your volumes and in that particular center. third important thing is recertification or revalidation is an important factor for a fellowship program to continue running. And in between periodic assessments by the fellow, basically you need to talk it out to your mentor. You can't tell your mentor at the end of your fellowship that I did not learn this particular skill. Every say around 1 month or couple of months, it has to be a joint meeting, one-to-one, which has to be without any major hustles or hesitations. It has to be an open meeting with open ideas from both the sides, and it has to be talked out with each other for getting better and better every time. As in, I remember Dr. Gagan Gautam, in fact, even Dr. Bakshi, everyone, Dr. Gagan Prakash, everyone probably asked me at the end of the fellowship what all things we could have done in a little better manner for the subsequent fellows' advantage. So it's a learning process for both mentor and the fellow, which happens over a period of years.
Okay, Indranil, I know the difficulty you had in the last days of because of the COVID, and you somehow jumped from US and came back. So what was your expectation when you went to US, and what is the reality after coming back?
Okay, so the expectation is based on what we believe and what we see in others, right? And most of the times it may be skewed or it may be unrealistic. So the most important thing is, one is trying to do a fellowship is setting the goal first. Why we want to do a fellowship in a particular study. Like for me, it was Uro-Oncology. And what was the final goal? Final goal was to come back to my own place, that is West Bengal, and start a Uro-Oncology program. So I think I have achieved that part. I'm happy with that. And also the other thing is the photograph on the guy who's wearing shoes. It looks like too much mainstream. And the guy who's wearing that torn up jeans, maybe a rock star and can be a trendsetter. So I may prefer the guy on the left side wearing that torn up jeans to be a trendsetter rather than being a urologist, general urologist, and being the too much mainstream. That will be my answer.
So I think that you had followed your passion, and the future, if you are actually having a lot of expectation, then it will be a misery. But if you are actually behind your passion, nothing will happen to you. That is what you mean, isn't it?
Yeah, that's what I'm saying. You can be a rock star and a trendsetter, but you have to wait, maybe.
Great. Yeah, good answer. Yeah. If Srivalsa is having a program, so that is why I felt. I think majority of the things Srivalsa has already discussed. Regarding other aspects like radiation, medical oncology involvement, and tumor board, all these things, how do you feel? And Srivalsa, you are having a program without any robot, and it is very successful. So what is your opinion about robot? Is it a must for the Uro-Oncology Fellowship?
So yeah, again, I think it is absolutely not a must.
You are muted, I think.
Am I audible now, sir?
Yeah.
Yeah, sorry for that. So if you look at it, if you have to really kickstart a program, I think the program should encompass everything, including a good volume of work, good exposure to the fellow, a multidisciplinary approach, so availability of radiation and medical oncology, and probably, if the fellow is lucky, access to research, basic research especially. I do not think for a country like India, where there's a significant dearth of uro-oncologists or probably even urologists who can actually deliver the right or the required care for a urological cancer patient, I think robot is probably not a must. That doesn't mean that we should shun technology. If it is there, it is an added advantage. But I think the current need of the hour for this country is for us to train, urologists to do good quality uro-oncological work, diagnose the patient, stage them properly, and deliver the right treatment required for them. I think that is the need of the hour. If there is a robot in the training facility, it's an added advantage, but I am 100% sure that it is not a requirement.
I totally agree with you, because if you are depending on the robot, there is no guarantee that after fellowship you may get a place to work, and sometimes you will be totally depressed. So if you are focusing on the fellowship, there is enough place to work for you. And both my Uro-Oncology fellows last two fellowship years, they are working in a center. And when I'm getting a message that they are done neobladder or IVC thrombus, I am very happy. Without robot itself, they are able to deliver. So that is what is required for our country at present.
Yeah,
thank you very much for
might add, sir, other commonly made statement is that you should know open technique because you might get into a difficulty while doing a robotic surgery. I think that's probably kind of a skewed understanding of why we need to learn open surgery. I think open surgery is a must because it can be done probably in any situation in a reasonable center. So we need not learn. So again, for the youngsters, I can just club it with the next question for you. I think they should not be going behind the technology, at least during their training. If they have access to good amount of clinical work, clinical exposure, I was really fortunate because I had two mentors. I got lucky because I trained in a very high volume center under Dr. Raval. I saw a lot of work happening. I was given a lot of hands-on opportunity, though I was not making the most of it. I still got, in plenty. And I was lucky that, when I came back to my hometown, I got my another mentor, Dr. Raghunath, who, right from day one said, you do the surgery. If there is a difficulty, I will come and bail you out. So the advice is that, please go back and look at programs where there is good amount of volume, where there is, a proper guideline based or a proper, structured approach to patients are there. And like I think Dr. Vivek mentioned that, or Ashwin mentioned, an observership prior to joining the program is probably extremely important. Maybe they can spend 15 days to a month just observing what the program does. And I think when you are done with the fellowship program, you should probably go back and reach out to another mentor. I think that's probably the best way to, develop our training skills, and subsequently maybe 4 or 5 years down the line, they can start a good program all by themselves.
Thank you. Thank you all.
Thank you.
Over to you.
Thank you so much, Ginil. Really appreciate that. It is so nice to hear how things are shaping up. And I'm also very pleased to hear the insistence of knowledge-based and disease-based approach rather than the technology-based approach. Thank you so much for the message that is being conveyed. Really appreciate the moderator and all the participants as well. Thank you so much. Now, it is time to invite our next session, Dr. Gagan Gautam, my very good friend, Gagan. He is given the task to find out what's happening right now in the fellowship program. Because uro-oncology has evolved a lot, as most of the seniors in this place, including, I'm not sure whether I'm called a senior, but we all learned open uro-oncology, open radical prostatectomy, open neobladder. The current generation of Indranil and Ashwin have learned a lot of robotic surgery. And what is that the youngsters today in the fellowship program gaining now? Gagan, please enlighten us.
Thank you so much, Raghavan. It's firstly, thank you for making me a part of this program, and secondly, thank you for making me feel young by actually asking me to moderate the panel.
You are not young. I'm so sorry, my friend.
I just colored my hair today, so I thought that would have some good impact. But anyway,
I appreciate that.
So it's actually wonderful and an honor and a pleasure to actually be have the young upcoming stars of uro-oncology who are currently doing the fellowship and pursuing their dreams. And before I head any further, I would like to invite my three panelists, and if they can switch on their cameras and unmute their mics. And in alphabetical order, I'm going to introduce them. My first panelist is Ashish Khanna, who is doing his uro-oncology and robotic surgery fellowship at the Rajiv Gandhi Cancer Institute and Research Center in New Delhi. We have Dr. Sridhar, who is doing a fellowship in uro-oncology and robotic surgery at the Amrita Institute of Medical Sciences in Kochi. And we also have Tushar Aditya Narayan, who is pursuing his fellowship in robotic pelvic oncology from the University College London Hospitals. So we have the future of uro-oncology right in front of us in the form of these three dynamic and young fellows. So I'm going to throw a few questions at our panelists. I'm going to stop my screen sharing. This is going to be a little bit of a freewheeling kind of a discussion. So to start off, I'm going to ask you, and any one of you can start answering these questions later on. Why did you join? I'll ask Ashish first. Why did you join the Uro-Oncology Fellowship? And and were you willing to give up all the other aspects of urology when you did this?
Good evening to all, and thank you so much for that question, sir. I have been trained during my MCH program from PGI Chandigarh, and so I was fortunate to have quite considerable exposure to the field, entire spectrum of uro-oncology at PGI, including all the technological armamentarium in the form of open, laparoscopic, and robotic surgery. And I chose uro-oncology because this field was the one that excited me the most about urology as such. And that's about it. And yes, I strongly believe that my passion for uro-oncology is strong enough to forgo of all the other parts or aspects of urology at this time.
Fantastic. At this time or forever?
Forever. Hopefully forever, because I think I'm enjoying what I'm doing here at Rajiv Gandhi, and I want to continue the same.
Right, Tushar.
Hi, sir. Hi.
Technology.
Yeah, hi. Thank you.
Glamour.
Thank you for that question.
Money.
Yes.
Yeah. Technology, glamour, money. What? All of the above.
First of all of you, enamored by all of you. That's the first thing. And then I have worked as a general urologist when I was at AIMS, and I've worked in uro-oncology when I was with Dr. Sudhir Raval. So I've experienced best of both worlds. And I've seen what urology involves, what uro-oncology involves. And at the end, I realized uro-oncology was my calling. I wanted to only get into cancers, treat cancers, prostate cancer, bladder cancers, having done general urology also. And that's when I realized that it's now time that I limited myself to uro-oncology and pursue uro-oncology further.
Fantastic. Sridhar, inspiration from Ginil, your mentor?
Yeah, I'll come
Some other reason?
Thanks for the opportunity. I should also thank my mentor, Professor Manal Kumar, to make me sit here. Thing is, when I started my MBBS, then itself I decided I should pursue a career in urology at that point of the time. Because when I saw during my MBBS days, the urologists were the cool surgeons, they don't have any calls. So I'm more inclined towards doing a urology, right, during the MBBS time. But your teachers have a lot of influence on your career. Okay, so during my MCH days, when I saw the work done by the uro-oncology team, I gradually started having an inclination towards uro-oncology, and finally I ended up with uro-oncology.
And is your passion strong enough to make you continue this for the rest of your life and give up everything else?
Yes, sir. So it changed completely during my MCH.
Fantastic. So
my passion still, I was having small doubt whether I should be continuing with the urology or should go on with uro-oncology. During the end of the MCH training, I had this big doubt whether you should have a comfortable urology life or you should go on with your passion. Finally, passion won. And I think
why settle for the saphenous when you can go for the jugular, right? So Tushar, you were wanting to say something.
Yeah, so I agree, sir. We've all been talking about passion, about uro-oncology. I think all of us share that. That's why we are into uro-oncology. But I would also like to add that there's no denying the fact that there is some bit of glamour, there is some bit of money involved, which drives all of us. Obviously, passion has to be there, but then glamour is there, the money is there, the robot is there, and all of us are driven by that also. So that's
Tushar,
also true.
Thank you for your honest confession, and I completely agree with that as well. Ashish, what are you learning now? What are the positives in your program? And I think Dr. Raval is logged out, so you can tell me the negatives of the program as well. Don't take my word for it. He may still be logged in. Sir is right there.
So at Rajiv Gandhi, when I joined, I've always felt that I'll become the person with the people I spend my maximum time with. So I have been very fortunate to be spending my time with my prime mentor, Professor Sudhir Raval. I've been able to learn from him a lot from him. In addition to that, as our previous speaker said, I'm fortunate that Rajiv Gandhi has a high volume center. So during my stay, I've been able to clinically evaluate, manage, and
did we? Yeah. Right, Ashish, please carry on.
So I've also had the opportunity to train in an important aspect that is the MR fusion biopsy that for carcinoma prostate, and in addition to that, have been able to see new techniques such as the radius sparing approach to radical prostatectomy. So all in all, it has been a wonderful experience, and I've been able to, I think, experience what the world of uro-oncology has to offer to me.
Fantastic, fantastic. Tushar, what do you think? Do our fellowship programs contain enough hands-on experience, and you can combine your overall fellowship experience when you answer that question? Is there something that we can add on to the fellowship program to make them better?
Fellowships in India, you mean, sir?
Yeah, India, UK, your experience.
So my experience, what I felt was most of the fellowships in India are for 1 year. Oh. And what I saw from the fellows who were trained in India, I think 1 year is a little short duration of time for you to be completely trained in everything of uro-oncology. Uro-oncology sounds like a very subspecialized subject, but now I realize that uro-oncology in itself is a huge subject. Because I'm at a center which is just doing prostates and bladders. So for the past 1 year, I've just been learning prostate and bladder surgeries. I think 1 year is less for that. Now coming to uro-oncology, which also has kidney surgeries, testicular malignancies, penile surgeries, combining the medical and the radiation oncology part also, I think 1 year is a less time. And at the end of a fellowship in India, at the end of 1 year, I think we are not trained enough to go out and be a good uro-oncologist and treat our patients. So
Sridhar, do you agree with Tushar? Do you think that the duration of the fellowship should be increased? What is your duration? And tell me some points about your
duration, sir.
Okay.
Mine is a 2 year duration. As Tushar was telling, 1 year is not adequate for a uro-oncology fellowship program. In 1 year, you will be learning the basics of the surgery and patient care. But to get a better hands-on experience and better understanding of everything, and to manage the complex cases and to have a wide spectrum of exposure, I think 2 years is necessary.
And what is your take on how your fellowship is structured, Sridhar, over these 2 years? How do you go from one step to the next? What are the positives and negatives of your fellowship program?
So I was trained at the same center for my MCS training. My ambition and my idea at the end of, at the beginning of fellowship program was I should be able to do at least what half of these people are doing at that time. So to begin with, it was kind of a structured training. My mentor sees that whether I'm progressing each step, and as I keep on progressing, he will give opportunity to proceed to the next step. So it builds the confidence, gets you trained in that step very well, and you can gradually progress. And by end of the 2 years training, probably you'll be trained in all the aspects of the surgery, and you get to know and get to see all the procedures, right from a level flow thrombus to a intracorporeal neobladder. We get to see all the cases. So by the time I will move out, probably I'll be able to do all those things as well.
Fantastic. So I think the common theme is that for proper hands-on training, probably we have to consider increasing the length of the fellowship, the duration of the fellowship of uro-oncology. And I'm sure the seniors and the mentors are taking note of this particular expression that you have. We have just time for one more question, and this question is for all three of you. Short answers, 30 seconds each. Your plans after the fellowship. Ashish, stay in Delhi, go and work somewhere else, stay in the same institution. Have you applied for a job yet?
Actually, I have. I wish to continue at my this parent institution because I feel that I fit in well with the team. We have gelled good enough, and I think I can contribute to the system, already existing system, and can learn a lot from it. So I hope to continue here.
Ashish, are you putting in a job application through this meeting to Dr. Raval, or you've already talked to him about it?
And I hope he's listening.
Gagan, has he given this idea to you already?
Well, we had a secret chat before we started this program. Sridhar, what's the plan? Stay in Amrita, go somewhere else, come to Delhi, work in Max.
Given opportunity, I will stay in Amrita, sir. Given opportunity, but there are a lot of other factors as well. Your family has a big role where you need to settle back. So I haven't decided. Still, it takes a lot of time.
Ginel is carefully looking at your comments. Tushar, are you going to stay there or are you going to come back?
No, I'm coming back. So I'm planning to finish my fellowship in this pelvic oncology, and then I come back and then I'll approach one of you also.
Fantastic. So wish you, all three of you, a fantastic future. Thank you for your candid answers to direct questions about your experience, about your plans. And I wish you all the best for the future. And thank you, Dr. Raghavan, for this opportunity. And over to you from my side.
Thank you.
Thank you, sir.
Thank you so much, Gagan, and the panelists. Really appreciate it. As you said, with my gray hair, it is so nice to see some black hair in action as well. Gagan, you have a lot of that, by the way. And the point you made,
you just broke my heart, Raghavan.
The point it was quite interesting is to say that passion is very, very important. There is a lot of glamour element to it. I mean, thanks to people like Raval sir and Yuraja sir, who comes and operates and makes, or yourself, Gagan, and make us look at a radical prostatectomy as if it is nothing other than an excision of a lipoma. A lot of glamour is going with it. I think that is also a reason why people choose uro-oncology. Of course, technology is very important as well. As Sanjay said, a branch which is very, very intricately related to technology, urology and ENT. Really, really true. Thank you so much. We have 130 people logged in so far and adding upon. There are two questions posed by our Professor Narmada Gupta sir. Can I request Kulkarni sir or Raval sir to give an answer to those questions, please?
Well, thank you very much. I think this is a very apt question, and I have I have to make two comments on the last slides of the Dr. Ginil. One was research. And one of the points which I must drive home to the mentors is it depends on the mentors, and mentors should make their person to go for research. Back in 1984, I had done, for my thesis purposes, cell surface antigen studies, taking bladder tumor slides and getting into the main aim. My boss told me was that you should get the only spirits how to do it. You need not make any big issue, but you must get that habit. Thirdly, also, secondly, other thing which you talked about, radiation oncology and medical oncology. Well, during our times, Dr. Ganesh will remember, we used to, put Howard's applicator ourselves because there were no residents in radiotherapy. And we used to give medical oncology, these cisplatin-based treatments for testicular tumors ourselves. So we do have that experience. So coming to the point, yes, I think Dr. Ganesh has already said that there is a set program which includes the rotation to the medical oncology, radiation oncology, molecular biology, and perhaps some basic research. And the program should be minimum 2 years, to my mind. Thank you.
Sir, Raval sir, any comments? And also a comment from NPG sir about robotics as well. Any view on that matter?
Yeah, no, I saw those questions, Dr. NP Gupta. Actually, he has asked very relevant question about a structured program. As on today, since the fellowship is not structured from like national board or something, every individual center is having their different type of curriculum. But I agree that it should be there. It is not there right now, except in probably TMH, which Ganesh has written already in the group. Coming for robot, I tell you many times now people say that uro-oncology is in high demand for robotic surgery, but that's not correct. When I joined uro-oncology, there was no robot in the market. There was no robotic surgery. Only thing later on came is the laparoscopic surgery, and doing laparoscopy in cancer was again a very difficult task. So we evolved as an open surgeon in uro-oncology, and the centers which are not having the robot, that doesn't mean that they can't have uro-oncology branch. They definitely can have. they can do very good job as open surgery. And in cancer, besides the surgery in uro-oncology, there are a lot of things which matters, like we discussed about medical part, radiation part, and the basic research part. So robot is not mandatory. Many people actually now they say that this is equal to robotic surgery, since robot is mainly used in cancer surgery. But there are places in uro-oncology still where you can't use robot. So I'll say that robot is not must. If you have, that's fine. If you don't have, you can still develop this branch.
Thank you so much, sir. Thank you so much, Professor Gupta. He is a doyen for us, and a question from him is very important for us to make sure that the question is answered. It's time that we move forward now. We have heard from the fellows. Now we need to hear from the bosses. So I request my close friend Raghunath to come on stage, introduce the program directors, and take it forward.
Thank you, Raghuvan. Very good evening. So after enlightening panel discussions from Dr. Gagan and Dr. Ginil, we will move on to the next few talks. That's about what do we expect from program directors. So to address this, we have 3 excellent talks. One is from Dr. Ganesh Bakshi, is the program director's point of view, is going to talk from Indian perspective, and we have Professor Manoharan, Murugeshan Manoharan. He is from Miami Cancer Institute. He doesn't require any introduction. And to tell us about UK perspective, we have Manal Kumar. He is a Viral Training Institute Uro-Oncologist from UK. Welcome you all, sir. And without wasting much time, already we are 6 minutes behind schedule. I welcome Dr. Ganesh Bakshi to talk on this. And we have the 4th talk by none other than Dr. Raghavan. He is going to talk about life of uro-oncologist. Is it a bed of roses or thorns? So without wasting much time, I invite Dr. Ganesh Bakshi to talk on Indian perspectives. Dr. Ganesh, over to you. Dr. Ganesh? Dr. Ganesh is there?
I think there is some gap. If it's okay, I can play Dr. Mano's video if Ganesh is not there.
Yeah,
shall I play?
Yeah, please. Huh? Go ahead.
Yeah. Okay, I'll play Dr. Mano's video. So Mano sir is already logged in. Can you all see the screen?
Yes, sir.
Yeah, thanks.
It is a great privilege to be here today, and I want to thank Dr. Raghavan and other colleagues for the opportunity to speak today. I'm going to briefly talk about Urological Oncology Fellowships and give an overview of the next 10 minutes, but I would like to spend more time answering questions from the urologists who are planning to apply for fellowships in the urological oncology in the US. I do not have anything to disclose. One of the common questions young urologists ask me is that what is the difference between a residency and a fellowship? Everybody has got a different take on this and different understanding. Usually a residency means for a young doctor who's planning to do urology, and you join a program where the mentors, the teachers, and the faculty will actually teach you urology. You learn from them by teaching. Whereas fellowship is more for people who have already done urology. And by definition, fellowship means you have a mentor who's like your comrade, like a friend. And you're going to learn from him, but he's not really going to teach. Technically, they teach you, but you really learn from them all the good things and also know the bad things and not to do them. It's more like you want to be with your teacher and emulate them, and you're preparing yourself to be a consultant or a faculty. So that's the main difference between a residency and a fellowship program. It's more focused, and you want to learn particular skill sets and a particular area of expertise, and then take it from there. In the United States, there are about 6 different fellowship programs available, including urological oncology, endourology lab robotics, female voiding dysfunction, and female urinary reconstructions. And the 4th one is men's health, infertility. We also have pediatric urology, And also the sixth one is reconstruction and trauma, particularly the upper fracts and other things. Out of these 6 programs, 2 of them, the pediatric urology and some of the urogynecology fellowships, are ACGME accredited. So when you talk about accreditation, we have 2 things. One is accredited by the Graduate Medical Education Committee, and the other one is non-accredited by the ACGME. What it means is that if a fellowship is ACGME accredited, it usually leads to some board exams and board certification, which allows you to practice in US in that particular specialty. But it is only applicable, or only people who have done ACGME approved residency programs in US or Canada can join them. So most of us in India and other countries will not be eligible to apply for these fellowships. Whereas non-ACGME fellowships, they don't lead to board certification, but it is open to everybody to apply to this fellowship programs. So particularly people from India can apply to non-ACGME fellowship programs. Urological oncology, none of the fellowship spots are ACGME accredited, meaning that all of you can apply for these programs. It's up to the program director and the program to choose the international applicants or not. So none of the urological oncology fellowships in the US currently are ACGME accredited, and they're open for you to apply. Most of the fellowships, like you can go to the Society of Urological Oncology website, where they list number of programs which are recognized or accredited by the SUO. It doesn't mean anything. However, this society recognizes these fellowship programs. And we also have the Endourological Society. But theirs is not truly oncology fellowship. There are endourology fellowship. They throw in laparoscopy and robotics to make it partly oncology, but they're not recognized as oncology fellowships. But there are jobs available in these things. But many more programs are independent programs. These institutions run their own fellowship programs, including many in Florida, including Jacksonville, our programs, University of Miami programs. They all have independent fellowship programs. As I mentioned earlier, none of them are accredited by ACGME, and it's open for you to apply for them as long as they're willing to take you. The other question people ask us are, what about robotic fellowship versus urological oncology fellowship? If you truly want to practice urological oncology, it's better to undergo a proper urological oncology fellowship program, get exposed to different facets of urological oncology, and get trained and practice your trade. In my view, robotic fellowship probably is not a true oncology fellowship. Robot is a tool. You just use the robot to do a procedure. You can do pyeloplasty, you can do pediatric urology, you can rebuild a ureter, but everybody in the modern days can use the robot to do a procedure. And calling that as a fellowship does not appear to be really a right thing to do. And believe it or not, every single urology resident coming out of the US right now or many other countries, they're exposed to robot. So if you just get a fellowship that you can use a robot, I don't think it'll be a very useful fellowship in the long run, maybe temporarily for a year or so, 2, 3, but not in the long run. So trying to do a formal urological oncology fellowship rather than a so-called robotic fellowship is somewhat not a true fellowship. So when you want to apply for a fellowship, there are a few questions you need to ask yourself. First of all, do I need to do the fellowship at all? If your answer is yes, then you have to start thinking what fellowship to do and where I would like to do. And then you need to think, once I finish the fellowship, what do I do with this? The skill I learned, can I use it and practice it in a place where I'm going to live the rest of my life? These are the basic questions you ask yourself. Once you ask these questions, a few things you need to consider. What is important to you? Is the mentor or the teacher or the consultant you're going to work with is important, or is the program is important? There are a lot of programs that are famous programs, sort of high volume programs, cutting edge technology. Or you have a mentor who's in a smaller program and is available and is willing to teach. So which one to take? It's ideally a great mentor in a great program is the ideal one. but not all the time you get this. Look out for it, but you have to choose between the two. I'll rather go for the best mentor, because as a fellow, you're going to spend more time with your mentor. And if he's a good person, is willing to teach, and he's willing to share all the tricks he's learned, that'll be much more useful than going to a program which is well known, but you don't learn anything. Second question you ask yourself is that, do I go to a program where there are residents or there are no residents? There are goods and bads about each of them. Think about no residents. You get exposed to the consultant or attending regularly, and you'll be operating with all the cases throughout your fellowship. There is no competition. However, the downsides are, because there's no residents, you might end up doing on calls, taking care of the patients during nighttime, daytime. So that's a problem. Secondly, because there are no residents, every time you try to do a case or a big case, the attending will scrub them. So you don't have the true independence, or you don't develop confidence in doing very complex cases. Whereas when you have residents, obviously you have to compete with the residents for the cases, but it depends on the mentor. Excuse me. But the advantage is that once the attending knows you well, he might let you operate big cases with the residents, and you might be supervising from a distance. So you get the independence and confidence. And plus, if you actually teach a resident how to do a procedure, you actually become master at that. So there are advantages, like when you have residents in your program. The third question is, do you want to do research here or not? Some programs come with a research here, some of them are purely clinical here. This is the individual choice you make. First of all, if you're purely going to practice clinically, you're not interested in research. There's no need to do it. But if you're not sure about it, I'll rather invest some time in like a 6 months, 1 year in research, or part clinical, part research. The reason is, this is the only opportunity you're going to have to get exposed to research, to understand the field of scientific urology, how to write paper, how to analyze paper, etc. After spending the year, you don't have to do research at all, but it's a valuable experience. But again, it's an individual choice. With regards to the length of the program, ideally, it's nice to do 2 years at least, if not more. The reason is, in the first year, you're getting exposed to the system, you're getting to know your mentor, the teacher. But once you learn the system, learn what your consultant does, etc., and get into good books, etc., the second year of the year, they let you operate more major cases, more complex cases independently without them scrubbing in. That's when you really learn the nuances of the surgery and you get the confidence, etc. Whatever you do, the main thing is that you need to make sure that the quality of life is satisfactory, both for you and if you have family and children, the quality of life should be good. There are programs in the US which are popular. You go to work at 6 o'clock in the morning, do the same surgery again and again until 8 o'clock at night and come back. And maybe a great program, but the quality of life may not be good. Just these are a few things for you to think about. So next, moving on to the Urological Oncology Fellowship basics. Most of these programs are 1 to 2 years. As I said, it could be clinical year alone, or it could be clinical year plus research. Occasionally it can be 3 years also. Most places, the salary is around, like if they pay you as a PG postgraduate year 6 or 7, you get about $62,000 a year. And some places, including our programs, sometimes you get hired as an instructor or similar status. The salary can be $90,000. Either case, you can live reasonably well, and I don't think you will suffer, and you can have a decent lifestyle with a car, house, and etc. Both the candidate as well as his family and children will get health insurance most of the times. The hospitals do not normally provide accommodation. You need to find your own. With regards to the family, in the United States, again, I told you, health insurance provided by the employee, the education is free, and they're at least in the good quality education for the visitors, meaning like for the J1, H1 visa, etc. And unless you want to send your kid to your expensive public school, this education is very, very reasonable here. So with this salary and with the health insurance and the education, you can lead a reasonably good quality life during the tenure of your fellowship. The requirements, as all of us know, you need to do most of the places, you need to do USMLE step 1 and 2. Right now, they removed the USMLE clinical skills part. And so you just need to do the USMLE 1 and 2, the clinical sciences and English. And then you get an ECFMG certified. Once you do that, you're going to get a job offer from the program. Once you get a job offer, you need 3 other things. One is you get a visa to work here from wherever your country you're applying from. And you also get a training license in the state you're going to work. And then the hospital will also provide you credentialing to work as a fellow there. The questions the young fellows ask is, do I always need USMLE 1 and 2? Can I work without USMLE 1 and 2? Most times, 99.9% times, you do need USMLE. There are 1 or 2 programs which gives you institutional license, which allows you to work in that hospital alone, but it's very rare. For example, Russell Park provides you one, Loma Linda provides you also, but these are all extremely rare. It's better for you to plan and write USMLE 1 and 2. That way you are free to work in many places. The second question they ask is, do I need USMLE step 3? To work as a fellow, you do not need USMLE 3. However, when you apply for a H1 work permit, they ask you to write the license exam, which is USMLE 3. Sometimes they overlook it, but you need a USMLE 3 if you're really going to apply for a H1 visa, and if they're going to look into all the criteria, you need to have that. The third question, can I operate as an observer? By definition, observer cannot scrub, cannot operate, cannot even touch the patient. So it's purely the observership. The other question is, can I do a 3 months rotation as a fellow or a 6 months rotation? Most of the programs in the US, they do not have 3 months or 6 months mini fellowship program. It's not worth the effort, and it's very, very rare to see such a situation. And so, if at all the fellowship, the minimum seen is about a year. Next question they ask, or you want to know, is that about the visa. There are 3 kind of visas available for the fellows to use. One is a J1 visa, which is an exchange visa program, which is the most common and easy to obtain and standardize. The institution and the ECFMG sponsor the candidate, and the candidate gets a letter from their government, and with that, you get a J1 visa. With that, you can work as a fellow here. And the second visa is that H1 visa, which is a work permit, and the employee has to sponsor and pay a fee for it. And not every program offers H1 visa, but it is a standard work visa where all the computer engineers and many other people use it, and many of the fellows also get H1 visa. That every year it changes. Some programs offer it, some programs don't offer it. So nothing wrong in asking them. All that they'll say is no, but some programs do offer. The third one is that called as an O1 visa. People with outstanding skills, meaning like if you've got a lot of research or a special skill set, you're great in certain things, and using that skill sets, you can get an O1 visa. But most of the times, the new fellows use either a J1 or H1 visa. So what is the problems with the J1 visa versus a H1 visa? There's no major problem with the J1 visa, except when you want to settle down in the US or you want to apply for a green card. If you want to apply for a green card, the rule goes by, you need to go back to your country for 2 years before you get a work permit or a green card, which means that you need to go back to India and work there, not any other country. The only way to bypass that is that get a job called as a J1 waiver job within the US in slightly underserved areas, and you work there and you get a J1 waiver job, and after 2 to 5 years you do get a green card. Whereas when you're on H1 visa or in an O1 visa, you will be able to go for a green card if you're eligible, and there is no restrictions like going back to the country. So if you have some idea of settling down in the US, try for a H1 visa. Obviously, if it's not available, then you can go for J1. The application process as you know, you need to start the process somewhat early, at least 1 to 2 years in advance. For example, if you want to apply for 2024, better to start soon this year. There are two kinds of programs are there. One is a SEO, like advertised jobs in the websites or in the urology societies jobs. But many more jobs are available by the independent programs where you apply directly. And you find about these jobs into the internet, through friends, word of mouth, and the vacancy positions advertised on the internet and the websites. So either you go through the societies like SEO or you go through direct applications. In the Society of Urological Oncology, the website gives all the information there straightforward. You need to apply about a year earlier. And you apply first and then you call for interview and then it's a match process. Sometimes you can also get hired out of match directly. But there are many, many positions are independent positions. For example, in Jackson, Florida, there are 2 or 3 positions applied. They're available and you need to apply directly to the chairman and he interviews and then picks up the candidates. So mostly in those situations, you apply directly, you get interviewed and they go to the referees or your referees speak to them and then you get hired. So either it can be through the match, which is all the information available on the website, or you need to do an independent application. When you're applying independently or through the match, a couple of things are important. First is network. You need to speak to people, get to know people, keep in touch with the people. That's one way of people knowing. For example, if I want to hire a fellow, either I should know the applicant directly and I trust them or respect them, or his referee should be known to me or somewhat remotely known to me that he can speak for you to give me confidence that if I hire this person, he'll be very safe, hardworking, and honest person. So networking and references are very, very important. Secondly, if you can, please visit the center. Come to US, spend some time with the center. For example, if a candidate comes this year and spends a month with me as an observer, and 2 years down the road, he wants to apply a fellowship, if I have a good experience with him and good rapport with him, I might consider him positively. Another thing you can do is that you can come to the American Urology Association meeting or a SEO meeting or ASCO meeting where you spend a few days, meet a lot of people, interact with them, get to know them, or they get to know you. And more importantly, if you're presenting a poster or giving a talk, it's even better. These are the ways to get your chances brighter when you're applying for a fellowship in urological oncology. There are a few websites which you know already. The most important website, if you want to go through the match, is the SEO website, Society of Urological Oncology. As I mentioned earlier, I really do not think the urology site is for urological oncology, but if you believe in so-called robotic fellowship, you can look for it there. Another website which I strongly recommend for you is the urology vacancies advertised. In the American Urological Association website, they constantly update it. Suddenly a program needs 2 fellows, they advertise it, and it's somewhat easier to get in compared to going to the match and other things. But what works best is if you have a personal contact, as I said, networking, that is one of the important tools to get into good programs. In summary, urological oncology fellowships start planning early, perhaps as soon as you start the urology training. Carefully plan and sit with exams, and you need 2 to 3 years planning and think about it in advance. Choose wisely and carefully, and once you choose, stay focused. And research various programs, talk to different people, your seniors and fellows, so that you get to know more and more about the fellowship programs. As I mentioned, possible visit US and visit the medical center, and also the bigger conferences like AUA meetings. But what is more important is, once you finish your fellowship, what to do. Are you going to go back to India and work? Are you going to go and settle in the US? Or are you going to go to other countries? Have a focused plan on a daily basis. So be prepared for changes and have outside plans and consider. Lastly, life is a journey. Fellowship is a journey. And the goal should be happiness and fulfillment, not just doing anything without things. Thank you for your attention.
Thank you. Thank you so much, Mano sir. I apologize for a brief transit of my screen sharing screens. I'm so sorry. It was such a wonderful talk. I had the privy of listening to the talk even before I projected on the screens. It was great. Thank you so much for that. I hand over the mic back to Raghunath now, please. Raghu, Ganesh is ready now. Raghu?
Yeah. Raghuvan is slightly logged out, looks like.
I think it's muted.
So should I continue?
Yeah, Ganesh, please go ahead.
Yeah, thank you, Raghu, and thanks for this. After Manoran sir's very nice figurative and number-wise presentation explaining in detail the US one, this might be a slight hard talk or a facts kind of things in Indian fellowship. To begin with, I give my regards to all my teachers who are there on this group today. JNK sir, Raval sir, Ganesh Gopalakrishnan, Kekre sir, and I have learned a couple of things from Manoran sir when I first visited US long back. And my colleagues also, because Ginil, Raghavan, Sanjay, we keep on learning as we discuss things. Going ahead, this is the very brief content of this talk, but so some of the slides have got duplicated. I'm sorry for that, but it's because this seminar is so long and I'll still try to not go into the details of that. Is uro-oncology different? Oncology comes here. So cancer is something much different when you treat it out or within a specialty. And basically, it does need a very good basic knowledge, systematic thought process, and ability to put various thoughts together to tailor the treatment and offer personalized medicine, which we finally aim for today. Okay, so we all know that urology is a part of DNB MCH curriculum. Everybody learns these things, and uro-oncological surgeries, if I see today, they are done in medical colleges everywhere, private institutes. So done by many, and obviously what comes to us is low versus high volume, one of the two slides which Sanjay had shown in his initial presentation. So what attracts a person to uro-oncology? This is what I feel. It's increasing incidence, greater part of urology. Like if we see exam cases in a MCH urology, there are a good deal of cancer. Robotics, there is attraction to technology, as our 2-3 people in the panel said, glamour, passion, technology. So that is it, or just something more after a urology specialty. So these are some of the questions which I asked in an interview I have asked earlier in a Uro-Oncology Fellowship interview, which we have for 1 year as well as 2 years at TMH. So these are the various answers I get: to pursue a career in uro-oncology, to have an exposure of uro-oncology that they have missed during urology training, eyeing on a future job with somebody, or a peer pressure to do something like uro-oncology, attraction to robotics, and this is the last one, someone close had cancer and hence interested. So these are some of the thoughts on the faculty side about fellowship, to provide a training which is actually comprehensive, multidisciplinary, as Sanjay mentioned and Raghavan keeps on mentioning, hands-on, not that you're not learning anything hands-on, which is supervised, technology inclusive, so robotics comes there, in all aspects of GU cancers management. So to learn interaction with medical radiation oncologists and be a team, be a teacher to colleagues, like these concepts in uro-oncology need to be taught, and to perform some research so as to produce a complete uro-oncologist. Now, very short on the duration, we have a 1 year and a 2 years. So the 1 year would probably be for those who have inadequate or need an add-on exposure apart from your urology qualification. You would go back and do good uro-oncology up to a certain level. I don't expect that fellow to duplicate everything. May also refer some of that, his work, to a high volume center later on. And it can be for somebody who has already done some uro-oncology stint and wants some more high volume experience. So 2-year fellowship obviously looks to be a much more better, comprehensive, curriculum-wise wider, greater expectations from the institute also and from everybody. This person will have a clear thought at aiming for a career probably in this subspecialty, although not very compulsory if you are in a remote area or something. For 2 years, lesser exposure to the other sub-urology specialty branches. So you should really think when you join a 2-year fellowship. I think there should be reviews during the fellowship. Periodical reviews should be factored in between, as Ashwin said, actually not at the end of fellowships, and feedback about objectives on either side to find out, are we both on track? We should be able to focus on the lacunae and faculty to guide the fellow to fill the gaps they face. So if this system is strong, ideally I feel there should not be any exams, as 2 years is a long time. Then coming to some key areas which I would like the fellow to learn in the fellowship. So what happens is you learn urology or uro-oncology in your DNB MCH also. So what is different would be a clinical decision making, choosing between alternative modality of treatments for a given disease stage. It's often a complex balance actually of benefit and risk within variable time frame and a very dynamic setting. Patient safety can only be ensured when safe and effective decisions are made, and majority of surgical errors are due to errors in judgment and decision as opposed to actual technical aspects of the surgery. So to reach a finesse in this very essential process by the fellow, learning from the volumes at the center and also from the experience of the faculty there, and to learn a decision with multidisciplinary approach, whatever is thought best for the given scenario in the patient. So this would obviously need a good basic knowledge. It would take time to achieve this kind of clinical decision learning, making these decisions. And it also depends on how strongly this is followed at the institute where you take the fellowship. Second thing is surgical skills. So the aim in fellowship would be to become versatile in all uro-oncological surgery, unless you go to a specific like prostate or bladder center. So to learn surgical processes, the technology, technicality, intraoperative dilemmas and the solutions to that, and alternatives, and one is not feasible. So you should not be stuck up in the operation OR as a surgeon. You should know if one thing is not working, how to do the next. This is what I have learned in one of my fellowships from Dr. Kulkarni sir. But everyone has different surgical skills, so they cannot be made uniform across the world. Not easy to change the technique already learned in urology training. So it is a difficult task sometimes to even convince a fellow sometimes to change his ways and modalities. So program director should be able to identify and modify the techniques as per the comfort of the student. So surgical skills is a continuous learning process. I might learn something even now. Anatomy should be absolutely in the brain. Either you should hone good surgical etiquette or relearn some of them. You need to be a very good observer about what is happening around you and what is wrong, good, better, best. Open mind to learn skills from anyone around. Sometimes the teacher would be a very small person and you get a very small tip from that. Ability to duplicate the maneuvers shown, and it's not only robotics actually. Overall aim for a good quality surgeries, whether open or MIS. Learning and evolution. So in fellowship, you learn from a few people, not only one probably. Key is to pick up good things from your experience and amalgamate the thoughts. But success is to get these together and implement the better ones for the better outcome. Sometimes you just copy the faculty, sometimes you mix and match and you do evolve on your own. And this may continue, ever learning, ever adapting. Final product of fellowship may be a little evolved version of you with all the learning experience you have. Another important aspect which I see as a program director in fellowship is to become more responsible. So as self, this might be your future. Think, work, and be mature towards everything. Towards the patients in these counseling, disease managements, and other things. Towards caregivers. Many times we'll interact with stressed up caregivers. So I think we should be responsible. So towards uro-oncology as such, maintain ethics. As you go out later, avoid bias for particular modalities, technologies, and approach. Show it in your work then. Towards the institute, if one is trained totally and adequately. About giving education or keeping education as one of the basic thought. So for the self, keep basics clear, try to remain update in the fellowship, participate in academics within institute, unit, outside, keep a track of recent publications, landmark and reviews, and improve your teaching skills. And teaching others, as when you teach others, this is a very important thing. You have that confidence. And one thing is that if you are going to teach others, you're going to know everything yourself. So academic discussions with seniors, juniors are important. Teach the urological concepts which you have learned with all the others with you. You should instruct fellow juniors, assist them surgically when competent, as then at that OR you are the in charge. Now a small comment on research. Research makes science better. In India, this is definitely stunted or restrained due to many reasons. I am not going to deliberate them here, but it's a known fact. Ideal for fellowship in uro-oncology to have research, to provide opportunities for basic science research in genitourinary cancers, and to support work on development of diagnosis, therapeutics, and many other things. So at least what wishful things from a fellow would be to have an interest in doing research and willingness to spend that time for its completion. Many times the interest is either biased or half-hearted. This has been seen in various students, and this can be judged actually. So as Ashwin was saying, basic research, it is fine. But then we should all have a clear view, or you may have a clear view with your program director. Like I can put somebody in a basic research in an absolute manner at TMH. But then is the student really going to be interested? That is a big question. So more things probably which one should grasp is, one more thing is a teamwork. Within your smaller team, you know everybody, their potentials, and work together. Work together as surgeon, radiation, medical oncologists, and many others, as I have here, pathologists, nuclear medicine, nurse specialists, MDT coordinators, and many people in the OTs, and try to communicate, interact, coordinate, collaborate, because that is success finally. One last thing which I feel is that there should be a leadership, should be a virtue to achieve in fellowship. Now, it is many times not inherited. So what's important and would be better is to learn to be a leader. It needs actually taking that extra effort. And there are a lot of people around who are reverse. Like many people think like, why should I take all the trouble? But remember, this habit will never leave you even later. You will remain like that. So some tasks which you should deal as a leader are some controversial decisions, time management, case prioritization, discussions. You know, you have some different thoughts about patient management. Get into a debate with your faculty or anybody. And leader usually takes responsibility of the team. So what is desirable post-fellowship is, after fellowship, I would like the fellow to duplicate, improvise, and pass on the benefits actually in the society and community. To preserve the integrity and maintain ethics, become successful honestly by all standards, by your name, by your fame, by your money. Come on the professional networking scene, continue towards your presentations and publications at least. One small thing is how we assess in selection, since many people or fellows would be here. We do check the background in applications, check the need and reason of pursuing uro-oncology. Is it genuine? Is it for a want of robotics? Not for learning the rest, just peer pressure. Some basic responses in the interview, which tell us a lot of things, and the recommendations, if there are any, from helpful areas. We look at the past training and the output you have created from that, and do ask some direct questions which tell us very clearly that what you have done in your past trainings. To conclude, I think program director's role, it has a responsibility both ways towards the candidate, and we have to run the institute also. Selecting a good student is not easy, but we make an effort to check on profiles, and good selection is the key component to continue the legacy of running fellowships. But honestly, making that student good should be the aim. I mean, we can select a student and I am successful if I can really make that student good. It has to be a two-way process, give and take, may not work as a one-way. And as a fellow, wherever you join, you're joining a family. So everything remains good if you are also good. Thank you.
Thank you, Dr. Ganesh, for giving a lot of insights about program director's point of view. Without much delay, I would invite the next speaker, Dr. Manal Kumar. He is a consultant uro-oncologist and program director at Manal Training Institute, UK. His interest is prostate cancer and kidney cancers. Over to you, Dr. Manal Kumar. He would speak on options and opportunities of fellowship in fellowship programs in UK.
Thank you for the introduction, Dr. Raghunath. And I'd like to thank a very good friend, Dr. Raghavan, for giving me this opportunity to talk to you today about the fellowship opportunities available in the UK. I don't have any conflicts of interest. So I'll give you a brief overview of what I'm going to talk about. A lot has already been spoken by Dr. Bakshi and Dr. Manoharan. So I'll be giving you an overview on who would benefit from doing a fellowship in the UK, what are the entry requirements, briefly about the application process, and what to expect from the experience, and how does this fit into your long-term plans, and to look into that. So who's a typical successful applicant for a fellowship? In the UK, they are CCT holders, these are doctors who have completed their urology residency training, and so they have a certificate of completion of training. So from an Indian point of view, it'll be doctors who've done an MCH or DNB in urology. So for an international medical graduate, they should be comfortable with core urological procedures, and it is useful if they have some laparoscopic surgical experience, because that helps, especially if you're doing a fellowship which is you're looking towards more robotic experience. And they should demonstrate an interest, as Dr. Bakshi said, in urologic oncology, to see what they have done during their MCH or DNB program and what their output has been. So the entry requirements, you have to have a primary medical qualification that is recognized by the GMC, relevant experience as we talked about. Then one thing that is quite people sometimes overlook is the English language exam, the IELTS. So what I would recommend trainees who want to do a fellowship in the UK, if they're interested in that, to do the IELTS exam, that would make their path much smoother, because sometimes we find that people are offered a job and they haven't done the IELTS. And for eligibility for GMC registration, you can either do the PLAB or the MRCS, the general surgery exam, or you can apply through sponsorship through the medical training initiative. So the applicants that we get, a lot of them have done the MRCS exam. So, to make yourself competitive, it is probably useful to do the MRCS, but it is not necessary, especially if you're not planning to settle in the UK. So the fellowships that are available, these fellowships are actually not centrally funded. They are funded by individual trusts. So each hospital, they're kind of independent. BAUS last year has decided to set up a register and has appointed a couple of fellowship coordinators, but that is still in its infancy. Some fellowships gain approval through the Royal College of Surgeons of England. The Royal College of Surgeons of Edinburgh has only recently this year started an approval process. So the majority of fellowships would not have this approval. However, every fellowship in uro-oncology would be in the UK in a high volume center, as I'll talk about later, because services are centralized, and the training is monitored through the ISCP, or the Intercollegiate Surgical Curriculum Program. So what is the responsibility of the trust? So when they appoint you into a fellowship program, they assign a clinical and an educational supervisor. So you would have a minimum of 2 people supervising you. They would agree a personal development plan or learning agreement within the first weeks of you joining. Ensure that you get sufficient induction and with the system, the computer systems in the hospitals and things like that before you start working. And then you have access to training, support, and study days. So and you will be getting specific study leave, and there's funding available for that as well. And then the training is monitored through the ISCP, or the Intercollegiate Surgical Curriculum Program. This is the same program that monitors the numbered trainees in the residency programs, and you have an annual review meeting at the end of the year. However, there are regular appropriate assessments and reviews through the process. So you have an initial meeting, then every few months you will have an assessment and review of your progress. The GMC for all doctors in the UK requires an annual appraisal as well, so that's part and parcel of the training program. And all these trainees would receive a salary which is on the UK standard, which is in accordance with the salary scales for trainees. And at the moment, I think it would be about £65,000 a year. So this is the BAUS Fellowship Directory is being set up. It hasn't been set up as yet, but it's in the process of. So the fellowship positions, they are advertised on NHS Jobs and the British Medical Journal, but you can also, as Dr. Manoharan was mentioning, you can also use your network and contacts and contact individual hospitals and program directors, and that can help with your application process. And the interviews these days, because of COVID, are on Zooms or MS Teams. So this is from the BAUS website. This is quite a busy slide, but this shows about the International Medical Graduate Sponsorship Scheme. So the process starts with the trainee or the fellow being offered a job. So once you have been selected, then and if you don't have GMC registration through PLAB or MRCS, then you can apply through the Medical Training Initiative, and you receive, you can put in an application to the Royal College. They review this application. One of the things that they do in that is they get a letter from the postgraduate dean of the region to say that your training is not going to affect the training of the residents. And then if you're going through the Medical Training Initiative, you go via a Tier 5 visa, which has a limit of 2 years within the UK. However, if you don't have to go through the Medical Training Initiative, like if you've got the MRCS exam, then you don't need that, and you can go via the Tier 2 visa, which does not have a restriction like that. So from an American point of view, it'll be like the difference between a J1 and an H1, between the Tier 5 and the Tier 2. So if people apply, if staying within the UK is an option, then you should go for the MRCS exam rather than the Medical Training Initiative, I think. So briefly about the UK healthcare system, it is slightly different from, Sanjay talked about this as well in his excellent talk at the beginning. So the UK healthcare system has a single provider, and from a patient's point of view, it's free at the point of care. So what that means is that there is no real perceived conflict of interest. So you don't have a situation where patients are asking for second or third opinions. And so they expect that the care that they're going to be provided would be to a standard, and they have quite a lot of trust in the system. So one of the things that was done to improve outcomes for urologic cancer and uro-oncology over the last 18 years, they started 18 years ago in 2002, and uro-oncology is the only service, even within urology and also general surgery, that has been centralized in this way, where what they said in 2002 was that hospitals doing less than 50 pelvic cancer cases a year need to stop doing them, and they need to refer patients over to high volume centers. So the services available now are all in high volume centers. And the way this is monitored is through national audits. So till last year, BAUS was keeping an audit on all the complex cancers, and you could go and look at individual surgeon outcomes on their website, and that was available for patients to see as well. But that has stopped from this year, I think, because of funding issues. But for prostate cancer, we have the National Prostate Cancer Audit, which is a multi-year continuous audit, which also takes patient-reported outcome measures. So just separate from the surgeon and the treating hospital, the patients are sent out questionnaires about their experience, right from the initial diagnosis, their journey to the surgery, the outcomes of surgery, and data is monitored through the hospital episode statistics and things about readmissions, reoperations, complications, if the patient's been to theater post-op. And so there is scrutiny of outliers, and that is done to quite a detailed extent, to the extent that, for example, how many low-risk cancers you're operating on. So if you're doing more than 5% of Gleason 6s, you would be an outlier, and you'll have to, justify it. So briefly about Wirral hospitals, it's a high-volume center, so we do about 150 to 200 robotic prostatectomies. We do both salvage and Retzius sparing operations as well, about 30 to 50 partial nephrectomies, similar number of cystectomies, about 60 to 80 laparoscopic nephrectomies. Laparoscopic nephrectomies are not done robotically in most of the hospitals in the UK, primarily because you can't really justify the additional cost of doing them robotically. And some reconstructive procedures, we do only about 20 or so of those because all the pyeloplasties are done laparoscopically at our hospital. And then we support colorectal surgeons and gynecologists. We have our own database, so if, for people writing papers and things like that, there is data available. And as mentioned Dr. Manoharan, there is also access to national database, and you can recruit patients in the national and international trials. So what would an indicative job plan of a fellow look like? So this is the current fellow. The job plan is 2 days of theaters, Monday and Wednesday, robotic theaters. On Tuesday, he has a research and free session. Thursdays is for admin, and also alternate Thursdays there are robotic theater and transperineal biopsies. So the fellows are finding that they quite like learning doing transrectal and transperineal biopsies. So we do local transperineal biopsies, and then you have a clinic on the Friday and the SMDT, which is the specialist MDT meeting, where we discuss about 70 to 80 oncology patients every Friday afternoon. So that is a good learning area where the fellow will present the cases and we'll discuss the management. And they do a 1 in 7 on call, which is non-resident. So what can you gain from a fellowship? So it's a focused uro-oncological experience, surgical experience in a high volume center. But also important, and which has been highlighted in earlier talks, is that the diagnostic pathway, learn how to manage the patient properly in the so for example, we were doing 10, 12 years ago, we were amongst the first few hospitals to start doing pre-biopsy MRI scans. And, so you can tweak the diagnostic pathways as you go along, MDT discussions and presentations. The other thing that is quite good and focused in the British system is shared decision making. So asking the patient about what their expectation is from the treatment. Not everybody wants the same outcome, and and we discuss the different treatment options with the patients. And so the ultimate goal is for both a UK trainee and an international trainee is that they should be able to do independent practice. And as discussed, it's leadership, management. They conduct audit and research and have a good idea of clinical governance. So the other useful experiences are, teaching and training of specialist trainees, urology registrars, recruit patients into trials or set up trials. Then, as I said, fellows have found biopsies. And sometimes, if there is within your urology training, there were some lacunae which you want to brush up on. For example, a fellow had a lot of PCNL experience, but not ureteroscopy. So, those can be factored into their training learning agreement as well. So the other thing I would encourage people, who are looking at a fellowship is to see where they would see themselves in 5 to 10 years time. So where they would like to settle, that would, and that would depend what visa category they go in for, what are the opportunities available at home and elsewhere, and whether or not they need a plan B. Not everybody needs a plan B. So in summary, have clear objectives and goals. So 1 or 2 years or even longer. Do the English exam if you have a few years to apply for a fellowship, and get involved in research and presentations. And if you're planning to settle in the UK, then start taking the exams. So more advice can be available on the BMA website, NHS employers, NHS jobs, GMC, BOWS, and so there's lots of information available on the net. So if you have any questions.
Thank you, Dr. Manal Kumar, for giving very valuable information on the options available at UK. So I have one common question to all three speakers. That is, what kind of attitude and aptitude you expect from a candidate whom you are going to select for your fellowship program? I request Ganesh to answer this question first, then Dr. Manoharan, and lastly, Dr. Manal. Ganesh?
Sorry?
This question is a common question for all of you.
Yeah.
What kind of attitude and aptitude you expect from a candidate before selecting them for your fellowship program? What do you expect from a candidate?
I mean, in very short, interest, kind of passion to do uro-oncology, ability to stand hard work maybe, and if I need him to also be good to teach others at a certain level, junior to them. Research I would discuss with him, because basic and clinical research are two great different things. Someone may want to do, someone may not want to do. But clinical research or translational is still good. So interest in these things, a person who would be absolutely reliable, and some of the other things I think I can teach him.
Okay, thank you, Ganesh. Over to you, Dr. Manoharan, sir. Kindly unmute. Yeah.
Yes, thank you. There are several attributes and characteristics I look for in the fellow. Like there are 20 of them. It's difficult to say which I need, which I don't want. But for me, the patients are very important as well. So I look for somebody who's got empathy and kindness towards patient, and also like a honest and trustworthy doctor. But what I don't look for, I don't give so much credit, is they being a technically very skilled, because we can always teach them. That's, I don't want a really trained surgeon, skilled surgeon, but I really look for somebody who can hang out with, who can trust, who can talk to, and he should be teachable as well. So it's a very hard question to answer, but I look for a little bit of everything.
Thank you, Dr. Manoharan. Over to you, Dr. Manal.
Yeah, I would agree with all of that. And I think the person should have initiative. So, and you should be, not everybody will get opportunities during their training programs. So if they can show initiative where they have done more than what was expected out of them, they should be consensuous, and good team players. And as Dr. Manoharan said, good to get along with. And so if they've shown a drive and initiative and are reliable, then I think that is a good skill to have.
Thank you, sir. Any more questions? Raghavan?
Can I ask one question to all the program directors? Same question. What is that which will put you off in a fellow when you select? It's very important to know that this is an attribute which will not go well. All three.
If I have to start, one thing is there would be a definitely interview before the selection. So some of the things which you have said, it is very easy to find out in the later things that they are there or they are not there. So that itself will start putting us off. The few other things are taking smaller responsibilities, as you go up the ladder with time spent with me or any faculty with me. There can be 4 faculties, and then you should be very reliable and start evolving as a leader in that, because this is the branch you have chosen to end your career, or end the learning of your career and start the vast learning towards the patients.
Nice. Trustworthiness. Okay. Mano, sir?
You asked a lot of tricky questions. But what will put off, one thing which will put off is, maybe a couple of things. If a person, knowing something is important, but he should know what he doesn't know. Like if he becomes cocky and overconfident, that can ruin himself, me, and the patient. So I rather won't choose somebody who's egoistic, arrogant, thinks he knows everything. That will put me off. He just asked for one character, so I just said.
Yeah. Insight. So
that's what I'm about to say. Lack of insight. Yeah.
Lack of insight. And Manal, yourself?
Yeah, I was going to say that, the lack of insight. And if you feel that they're slightly disingenuous, I think lack of insight and being disingenuous or over smart or something, I don't know.
The two things which is spoken by all the program directors is trustworthiness. They should be genuine in their thought. And secondly, there should be insight into what they know and what they do not know. And that should come across genuine as well. So a fellow should know that, as Ganesh rightly put it, it's a long career pathway that we have chosen to do what we are going to do. So knowing yourself is very important in this journey. So I really appreciate the answers. Thank you.
So there was one question actually which I had not answered. Should I do that? From Naveen Kumar.
Please, Ganesh.
So are there any criteria to regulate fellowships in uro-oncology? There is no criteria, but generally no criteria. And the last was, is there any minimum number of cases to be assisted and to be independently performed? So
at individual centers you can put that, or we have that. But again, it is very clear that that does not mandate you to get those surgeries. If you are, say, not up to the mark, obviously you will not get those surgeries. You have to evolve with your mentor and faculty and the institute, and with a lot of your performance-based kind of incentive. I should not say incentive, but things are going to be performance-based. So that is how work will be generated.
Yeah. I mean, there are no minimum number requirements in most places.
There are.
In the sense that, a significant number of prostatectomies, even today in the US, are done by people who do 1 or 2 a year.
Okay.
Thank you all. Moving forward, we have very interesting talk by Dr. Raghavan. I'm sure this will be very interesting talk for, particularly postgraduates who are aspiring to become uro-oncologists. This talk is on life of a uro-oncologist. Is it bed of roses or thorns? Over to you, Dr. Raghavan.
Thank you so much, Dr. Raghunath. And first and foremost, my most sincere thanks to Sogo, Dr. Kulkarni, Dr. Raval, who allowed me an opportunity to do this. It is my passionate appeal to the postgraduates who are with me, as well as who keep on asking me the question about uro-oncology. I'm so happy that people are interested. And this program, hopefully, I strongly believe, would have opened their eyes towards what is uro-oncology, and the talks, especially from the freshly graduated fellows who are joint consultants and the program directors, would have really laid down as clearly what it is. I most sincerely thank all the participants so far. So it finally comes to the question of what is the life as a uro-oncologist. Now that I've become a uro-oncologist, what is that I'm gaining? Is that a nice thing, or is it a bed of thorns? I will start my presentation. So, uro-oncology, what is it about? We all know that uro-oncologist is a specialist who is a urologist with a special interest in oncology, who is trained to do complicated uro-oncology surgeries, and most important, manage these patients, tailor the treatment so that the side effects are reduced and the functions are maintained. Sanjay nicely put it at the beginning of the presentation. This oncology is not generic oncology. There is a lot more to this, because intricately related to this branch is the fact that a function of the patient is also a paramount importance to maintain as much as the cancer cure is. So, what is so special about this? It's long operating procedures, complicated operating procedures, very interesting cases. At least I find it very interesting. And there is definitely a lot of glamour associated with the branch as well, especially with the advent of the robot. There is also a lot of recognition that comes with the roses. Patients really appreciate, because somebody's cancer is cured. The society looks up to you as an oncologist. The peers respect you because you are an oncologist as well. There is a lot of recognition for you in the society. It is a very attractive proposition. It is almost boosting the self-ego as well. You also work with a range of people. You are medical oncologist, you're radiation oncologist, pathologist, radiologist, you're molecular biologist. Each of them, you treat them with respect, and they treat you back with respect as well. It is a branch which you uniquely work with a lot of people compared to many other branches in urology. And of course, robotics is the most attractive proposition in the whole thing. But a word of caution, across this whole webinar, you would have heard all the surgeons saying again and again, robotic surgery is not uro-oncology, and uro-oncology is not robotic surgery. That is part and parcel of it, but not the uro-oncology itself. And publication, you will have an opportunity to publish in very respected peer-reviewed journals, and you will be respected by your peers as well. Now, it has its downsides as well. First and foremost, you do an enormous sacrifice, your personal life, your hobbies, your commitments, and most importantly, a general urology practice. Now, I'm very sure it's a very similar situation to most of the uro-oncology practitioners in India, that you put across at least 14 to 16 hours of day every day, and it is at least 6 days a week. Most of your hobbies, you have to, fight your time to find your hobbies as well. Most of the time, it just carries away. Your commitment towards the patient is very high, especially when you're doing complicated surgery like RPLNDs or cystectomies, where patients stay for 7 days, 10 days. You are really sleeping on bed of thorns every day. And you lose your general urology practice. You are not doing PCNLs anymore. You are not doing your cystoscopies anymore. Anybody who knows my branch and this branch knows very well that doing 5 GA cystoscopies will earn more money than doing 1 radical prostatectomy. That is a fact of life. But we will be losing a substantial amount of that practice as well. As I said, a general urologist on any day clock much more earning than the uro-oncologist. But that is what their life is. That is what we are taking. In 5 years, it takes 5 to 10 years to become recognized as somebody in the specialty. So 10 to 20 years is when you blossom. At 15 years, you start questioning yourself, is this the right branch? I'm doing this. What is more for me beyond this? And this is where the 15 plus years is when it comes to training the next generation, research, publication. As Manal said very nicely, I was part of the viral team when the protocol for MRI before biopsy came into vogue. It was an amazing moment of discovery when we found that MRI was much more useful before biopsy than afterwards. But that thing comes at the 15th year of your practice. There is so much of competition. A surgical oncologist will do cystectomies, will do nephrectomies. A general urologist will do cystectomies and nephrectomies. Prostatectomy is not something people commonly do, but nonetheless, there are some people who will do that as well. And of course, general surgeon will be dealing with testicular and penile cancer. You need to stand apart from all of them. You need to prove to other people, the peers and your colleagues, a referring physician, that when a patient with a uro-oncology problem is referred to you, your management plan far superior compared to other people who manage as a patient. And that is where your knowledge, your skill, and your team working, your communication skill all come to fore. The outcomes matters. Uro-oncology outcomes were one of the most strictly monitored outcomes and published outcomes, at least to my knowledge in BAUS. As Manal said, till last year it was published. Each one of our outcome was available for public to see. Our deaths, recurrence, progression, what palliation we give, what are unresponsive treatments, and the rare tumors. We have to publish, we have to keep ourselves as an open book for everybody to see. And complications are no less in uro-oncology. They are major surgeries. Patients have incontinence, erectile dysfunction, they have stoma, radiation-related complication you'll manage, a post-penile cancer surgery patient with lymphedema you have to manage. So it comes with its own set of things. Everything is a compromise. So this is a bed of compromise. That's what I would call it. So if you genuinely want to do uro-oncology, you need to spend that extra time to become a uro-oncologist. It involves dedication. You need to attend the workshops, you have to develop your skills, your research, and also your ability to teach. All the program directors kept on telling one thing: your ability to teach the next generation becomes part and parcel of you becoming a uro-oncologist. You have to be updated. Roughly, these are the most important journal, and on every month you get at least 10 publications related to uro-oncology in each journal, out of which 3 are important. So roughly you need to be updated with about 40 to 50 articles per month in a very conservative way. And imagine if you are in touch with everything, it is much more than that. I don't think any other branch which has so much of articles being published and their ability to keep in touch with them as well. And everybody said it's very important as a uro-oncologist that you are part and parcel of research. It may be basic science research or translational research, clinical research, but it has to be there. Your research is the one which is going to make a difference to the next generation. You need to be part of it. You need to be aware of the statistics and everything that comes with it as well. It's a teamwork. You are not sitting alone. You don't decide who is the final patient who gets whether a surgery or radiation. You need to be with the tumor board and be respectful of the tumor board. You need to liaise with the team. You need to be respectful of the colleagues that are giving your opinions as well. It's a subspecialty. There's a long period of growth into the specialty from ABBS to general surgery, urology, and uro-oncology. However, I should confess that uro-oncology is not a pinnacle of the subspecialty. You can take it off and put endourology there. You can take it off and put andrology there. What I'm trying to say is that it is a unique set of skills that you need to develop to reach that point. And that is where I'm saying that it is a long growth with it. And of course, you should be having the ability to attract funds to, have a cancer hospital, research, appoint a fellowship program. That ability of attracting funding from other organizations is also part and parcel of uro-oncology program. So life of a uro-oncologist is a very fine balance. One needs to understand that this is not a bed of roses. It is not all about driving posh car and doing robotic surgery and removing prostates. It is not the doomsday of having cancer deaths. It is a life and balance between many things. And one has to understand that if you are willing to take this balance, then please welcome into the club of uro-oncology. Thank you so much.
Thank you, Raghavan, for an excellent talk. This is one of the wonderful talks I've ever heard in the recent past. Thank you so much for your efforts. I think you have spent a lot of time and energy to prepare this talk. Otherwise, without that, it's very difficult to prepare like this. Thank you for that. Thank you for giving very balanced overview about life of a uro-oncologist. And I'm sure if you have the right attitude, if you're willing to work hard, and if you're empathetic towards your patients, probably you can convert this uro-oncology into a bed of roses. I expect any questions, comments from any seniors.
Thank you so much, Raghunath. I really would want the final words from all the program directors, Mano sir, Manal, and Ganesh, as well as from JNK sir and Raval sir, because the next session is also a very, very interesting session. So before we move to the next session, any comments from all of them?
Raghavan, I just have only one thing to say. Your talk was a crown jewel. Thank you very much.
Thanks, sir. Thanks.
I can only say that it was absolutely crowning glory. Very nice. Great. And it's expected of you. As I said in the beginning, we gave you to bring in these points only and share your views. Thank you very much.
That is very sweet of you, sir. I want more people to come into the branch. As Sanjay said, there is so much of need for more people to come into the branch. But I want them to come with the understanding that this is what the branch is. It is not just about removing prostates and walking away the next day. It is not that. After removing prostate, you need to manage the patient for the next many, many years to come. Deal with their incontinence, deal with their ED, deal with the recurrences. And that is life. This is the life of a uro-oncologist. And if you are not willing to take that, this is not the branch. But on the other hand, if you are willing to take it, you are the most wanted member of our club. Please come in. Manal, any comments from you, Manal?
I was actually muted when I was seconding Professor Manoharan's thoughts that, that was an absolutely wonderful talk. You've covered it really well. And I would agree that, it is a nice specialty, but it does need commitment. It needs dedication.
Thank you so much. Thank you so much. Raghu?
Yeah.
Go to the last session.
Yeah. So we have another very interesting and important panel discussion, which is very important and interesting for practicing uro-oncologists. How to take this specialty forward. We have eminent faculty, eminent panelists, and we have this session is going to be moderated by none other than Dr. Sudhir Raval sir. We have very eminent teachers who will definitely throw some light on how to take this specialty further, how to develop this specialty in India. So I request Dr. Sudhir Raval sir to conduct this panel discussion. Over to you, sir.
Thank you, Raghu, and respected teachers, colleagues, and friends and delegates. It's my pleasure to conduct this session as a moderator where I have teachers like Dr. Ganesh Gopal Krishnan, Dr. Nitin Kekre, Rajiv Kumar, and Dr. Anish Srivastav. And then we have one of the pioneer uro-oncologists, Yuvraja, and I don't see Dr. Ajay Kumar. Is he there? I actually invited him.
Rajiv sir said he is logging out but logging in at 8 o'clock. So I expect him to join.
I'm here, Raghavan.
Rajiv is there. I know Rajiv is there.
Sir is here.
No, about Dr. Ajay Kumar, is he there?
Not in the faculty list.
Yeah, I don't see him. Anyway, but then I will be involving Dr. JNK also. And Raghavan has given me questions, but I have removed some question because he has answered those questions in his talk already. So with that, I will just go ahead with the panel discussion. And this actually is all about now whether we should have this fellowship or not, because we have Rajiv and Dr. Nitin Kekre who are in National Board, though Dr. Ajay is not there. First, I'll ask Dr. Nitin, sir, is this the right time for a uro-oncology separate branch which requires fellowship? Dr. Nitin, please.
I think it is absolutely the need of the day today, because not only that there are enough centers for doing the work, but it's extremely important for the urologist to go and practice uro-oncology and make sure that this happens. And this, unless you get a structured work or a structured fellowship, you always will be questioned. So I personally have absolutely no doubt that this is the right time, not only to have a separate fellowship, a proper training programs, so that you will produce well qualified, accredited uro-oncologists for the future.
So, sir, Rajiv, do you have any difference of opinion? You agree with sir, or you want to add something on this?
Dr. Raval, I'm supposed to read between the lines. So that's what I'm going to do here. I agree completely with Dr. Kekre that a fellowship is, you need fellowships and they already exist, and therefore they need to expand and become standardized structure. No doubt about it. But the other part of your question is that should it be a separate branch which requires a fellowship? I have an opinion that should it become something which is totally separate? Is it something that you cannot do if you do not do a fellowship? That's where I have a difference of opinion. I don't think we have enough people to say that in the absence of a fellowship, you cannot do urological oncology. My take on...
Yeah, go ahead, please.
My take on urological oncology is slightly different. I come from a general urology practice. I come from an institutional general urology practice. I don't call myself a urological oncologist. But 30 to 40% of all the work that I do or any of my colleagues in urology do is oncology. And therefore, to say that you cannot do oncology unless you are fellowship trained is something that I cannot see at the moment.
Yeah, that's fine, Rajiv. But looking at but there was a time when there was a general surgical branch only. They were doing cardiothoracic and urology and orthopedic even. So don't you think this is the time when this will take maybe another few years when uro-oncologists will be a totally established branch in future, or still there will be overlapping?
So again, let me go back to the same point that I was making. Separating urology from general surgery is a paradigm compared to what the change between uro-oncology and general urology is. To do uro-oncology, you don't have to be a uro-oncologist. But everybody who does uro-oncology does not become a uro-oncologist. We need to be clear about these two separations. And like I said, for a general urology practice even today, 30 to 40% of the work that gets done is oncology. And to assume that we have enough or we will have enough uro-oncologists in this country to say that no other urologist should do oncology work I don't see it in my lifetime, and my lifetime still has a few years to go.
Not viewers, many decades. So I'll ask the same question with Dr. Ganesh and then Dr. JNK. Sir, Dr. Ganesh.
I was hoping you wouldn't ask me this question, Sudhir, because my name is not on this. So I could actually decline.
Sir, Rajiv made it complicated.
I could actually decline to ask. But you know, there is a point in what both Nitin and what Rajiv said. Rajiv is talking from the point of view of a teaching institution. Nitin and myself have been in teaching institutions, and where we were very clear that in a teaching institution, these things must develop. We must have a specialty. We must have a Uro-Oncology Fellowship. My only worry is, what happens to this guy who's done a fellowship when he leaves and goes out? As long as he's in a teaching institution, in that department, he will grow, and that department allow him to grow. But when he gets out into the world, what is going to happen to him? In this world in India, we are talking of India, it's a rat eat rat race here, and I in fact put a question on the WhatsApp as to what is the data for the fellows who are, for the people who have done fellowship in the UK and the US. Yes. What's happened to them afterwards? Yeah, what's happened to them? Have they actually really done outside of their teaching, outside of their fellowship program? Have they actually gone into fellowship, into doing pure Uro-Oncology? I can only in this context commend the work of Murali Kamath and V. Srinivas, who those days, many years ago, decided that this is what they're going to do. And they had the passion for it, and they did it, and they've done well. But it's a long grind. So, you know, I think I'm in for a specialty. I'm in for a fellowship, because at this point in time in India, everybody requires some recognition. Otherwise, it will not happen. What did I do? I did Uro-Oncology. Where's your fellowship? I did the fellowship. So I think the fellowship in that regard is important.
Thank you, sir. I'll ask Dr. Kulkarni about the Rajiv Kumar's point of view, which he actually
in fact, I go back to the 1986 meeting of SUO, where I had a chance to attend, and Dr. Whitmore then also says his concern that you're going to do balkanization of the urology, and well, this was the thought which he had. Certainly, that has gone bad now completely. We have progressed to it. And today, as I see, with the demographically, the incidence of the diseases is changing in urology. Oncological diseases are growing more. In fact, when we were students, the tuberculosis was so common in genitourinary tract, which is changing. So even incidence-wise, oncological diseases are in urology, for that matter, in everywhere is coming up well, very high. So I think we need to have this kind of Uro-Oncology fellowship in not only in teaching hospitals, whether now, as far as the further he takes it or not, is 2-tier or 3-tier cities, well, he should be allowed to do general urology as well. But I think that will give him some kind of confidence in doing so many things, which is a much better way. I think that's my take on this.
Okay, sir. Thank you. I'll go for next question. Do we need a fellowship or just some extra time with an experienced surgeon? Dr. Ganesh.
I think we've already
have answered, but
yeah, I think we've already frankly dealt with this question.
Answered, yes, sir. But will the last part, the just some extra time with an experienced surgeon without any fellowship, because we don't have fellowship. I did not.
What do you mean by extra time? Just hanging around with him, or actually, as was discussed in this entire program, we need a commitment from the guy who's wanting to be there. Is he just coming there to pass time, or is he going to be there? As when he says extra time, he has to be there day and night. He has to be behind this mentor. He has to be behind this guy. Even when he is going home, he has to go behind him and discuss, and he has to show commitment to it. So it's not just being hanging around in a department. Okay. He has to be committed to it, and you can make that out. As a senior guy, as a trainer, you can make out who's the guy who's just coming for time pass sake, and the other guy is really absolutely committed. Then you can make it out. You can make it out.
Sir, I meant if suppose we do not have fellowship, as on today we do not have, and if we decide we should not have fellowship, as Rajiv said, he was reading in between in the line that he is doing 30 to 40% of the work as Uro-Oncologist. So in that case, if there is no fellowship, does the some extra time mean some work? If he has worked with a experienced uro-oncologist for 1 to 1.5 or maybe 2 years. Will this work, or I think everybody will agree for having fellowship? Dr. Kulkarni?
Yeah, I just wanted to, Ganesh brought in a point, which he said 1 year and 2 years. He actually meant what, you are saying, that some time can be spent for 1 year, which can be called as a certification course, which may not have too much of meaning. But if you have to have a uro-oncology career, then it has to be 2 years straight away. There is no in between.
Sir, what do you think learning continues throughout life? When we started, there was no lab and robo. Then we actually had to pick up.
Well, I think at the age of 60, I had to start doing robotic surgery. Otherwise, I would have been washed out completely. So I think this learning is a continuous process.
Yeah.
But I think that you have to accept that. Yes.
So will you say that after doing MCH, a urologist, he goes for 2 years for Uro-Oncology Fellowship? Isn't it too much, or we have to structure our whole urology training in a different way? I think I'll ask Dr. Nitin, because he is in NB.
Sudhir, you are asking questions which have many ramifications. The first question is, should we have a urology training after MBBS? That is, so the question is, what are we trying to achieve? We are trying to achieve that the young man becomes a super specialist within a specific period of time and has adequate surgical skills. Now, till we are able to modify the basic structure of training, it is difficult to basically comment on this. But what structure we have today is that the person has to do MBBS, then he has to do MS general surgery, then he has to qualify for urology, and then he subspecializes. So that's the structure we have today. The question is, basically, is that structure proper or not proper? I personally feel, sitting at a position where we used to see people today, it is actually quite disappointing. Because today what is happening, I'm sure Rajiv will tell you and other people who are training people, that people who come for MCH training, we are training them in general surgical skills. So it is a bit of a kind of a difficult situation, that the basic training right from MBBS, MS is weakening, and we are trying to create more and more subspecialists. So there is a need to look at all this phenomena that happen, because otherwise after some years, if you have a regular training programs all over the country and there is a huge number of increase in uro-oncology training fellowships, you still will be finding people who are not even trained in basic urology, that they can't do basic urological work, they do not have basic urology, but they are coming for uro-oncology training fellowships. So I think that's the biggest problem we face in this country. So one of the most important challenge we have, the standardization of training program, so that we know that if the guy has done MS general surgery, I don't have to teach him basic general surgery. So that is important. Till we answer that question, it is basically hypothetical. Based to answer that question.
Yes, sir. Thank you, sir. Okay, this is the question to Dr. Anish, Dr. Ganesh, and Dr. JNK. I think Dr. Anish can take this because he is in SGPI also. In the absence of basic research in corporate world, there are many uro-oncologists who are in private, including me, though I am in an academic institute also. This works as we have a basic research lab also. Center should be the fellowship or training in the uro-oncology or clinical research is enough, or we have more oncologists as we have more oncologists in private? So do we need basic research always, or we can get away without basic research? Dr. Anish.
So, good evening, everyone, and thanks, Sudhir. Actually, if you really, very crisp answer would be, we don't need clinical research if basic facilities are not there.
Molecular research.
Yeah. So, that's molecular. Like in my department and in many other places, we have research labs, and we have basic scientists with us. You have seen a lot of papers in cancer from our center in Uro-Oncology. So it is good. But when we are talking about overall, and if the research facilities are not there in a particular center, like for example in your center, it may be difficult for you, to create an infrastructure.
No, we do have, sir.
But of the same
about other corporate world, you know,
no,
a lot of uro-oncologists are in private in a corporate.
That's right. So you do have, but not to the extent, because that also is a relative term. If you see, like we produce here about 30 PhDs in a year, right, from SGPGI, at least 30 PhDs. So this is all relative. So we have, you know, in every nook and corner, the basic scientists are sitting, and you know, you can do a lot of work when it comes to molecular biology. We have genetics, you know, so it's a relative term. So if you go into like that, that is what I'm trying to say, that one may have limited research facilities, or one may not have even the research, the basic science research facilities. But we still need to train people in uro-oncology because we need people, you know, providing clinical services.
No, good. Dr. Ganesh, thank you. Dr. Ganesh, any difference of opinion here?
I believe that there are two types of corporate worlds. One is a corporate world where it is purely to get the rupees, annas and pies. No question about it. Mm-hmm. The other corporate world is where they are willing to accept that yes, there will be some degree of research, and these people do have a degree of training in them. They have accredited training, DNB or whatever it is. And basic research is not necessary. When I'm telling you molecular stuff. Yes. Everybody can do research. It doesn't mean that you go down to the molecule and do it. That's for people who are really committed in certain labs, in certain institutions. And let's agree with it. The real corporate world is not interested in this country in all this basic research. Yes. They're not interested in all this. They want to get their coat, they want to get their bread and butter all sorted out.
Yes, sir.
So this is to be at a different level.
Rahul, I have a slightly different view. You know,
yes, sir.
What his aim is, he should be exposed to what is research discipline. And for that matter, if you don't have the research facility, he can be trained or sent for a sort of a 1 month fellowship or 1 month training just to understand what happens. So he gets into, suppose he goes to a situation at a later date where the research may come positive or maybe be possible. So he should not be left high and dry. I think just disciplines to be understood. Maybe 1 month or along a touring fellowship or traveling fellowship, some kind of thing can be arranged between the two institutions. And I think that would be a great thing to have.
Yeah, that's a great idea, sir. It's just I put this question because basic research is part of cancer treatment or cancer whenever you are dealing with the cancer.
You know, Rahul, one more thing which I wanted to, in the previous question which we were asking was, there's another group of people who are coming up, which is of course not there in the US and UK. He is a general surgical oncologist. And let me put it what I mean by that. There are students who have finished their MCA general surgical oncology. They have rotated through the uro-oncology service in them. They are equally trained. They were already actually residents and they had done a lot of good surgery. And they come and ask me, what is that? Why can't I become a urological oncologist? Because it's oncology. You are also starting a fellowship. Why can't I be eligible for becoming a diploma in uro-oncology? As it happens in gynecological oncology, if you know, by gynecological oncology, yes, now the degree which is started, who are the applicants? MD gynecologist and MCA surgical oncologist. So I think this is one area which is not there in US and UK. They don't have degrees in surgical oncology. But here are the significant number of people who are coming up across the country. And nearly at Tata Memorial, I was told 16 registrations are coming up every year. So 3 years, 50 students are coming out. So these are going to ask it. I would like Nitin to, or maybe Rajiv to answer this. How
before that, can I say this?
Yes.
I went to Bern and I was with a student for 2 days, and I met a guy from Brazil. And in Brazil, they have same problem which we have, that surgical oncologists doing uro-oncology or they're doing nephrectomy. We are not as evolved as in America. If you go to best center, they are even organ-specific surgeons sitting. Yes. So that's the matter of time probably in future. But definitely this question, Dr. Nitin and Dr. Rajiv can also put their views on this. Dr. Nitin?
I think it's a very important question. It's basically a turf fight. We're already seeing it. The people who are oncologists, general oncologists, feel why can't they treat uro-oncology as well? The it is the same fight exists between pediatric surgeon and so-called urologist, pediatric urology. I think we are talking about techniques. It is far more important to talk about the science and decision making of uro-oncology. And I very strongly believe that the basic training in urology is far more important to become a uro-oncologist than a general oncologist being a urologist. So yes. I'm of an opinion that over a period of time, that's why it is important that the uro-oncology centers, academic institutions must develop a program of uro-oncology which happens after the urology qualification, which will make qualitatively difference between them and oncologists. Because otherwise this will never end. So I am very that it should be a urologist domain to practice uro-oncology. The urology training is far more important to practice uro-oncology than just a general oncologist.
Agreed, sir. Rajiv, your thought?
So I agree with Dr. Nitin has said, and we go back to the basic genesis of what we've been talking about for the last 2.5 hours. What is a uro-oncologist and what Raghavan said in his talk? Just because I can do a radical prostatectomy, I can do a laparoscopic nephrectomy, or I can do a cystectomy, and my results are almost as good as somebody who has a 5-year training, doesn't make me a uro-oncologist. And that's the primary difference between what a technically good, gifted surgeon who can do a good surgical job versus a person who's dedicated to the specialty. So he will tell you when should an MMR test be done, when should an MHSI be tested, when should Pembro be given, when should Pembro not be given, why should it be given, what is the most recent research in it, why is this technique better than the other. Now, this is required maybe in 10% of the patients who need it. But then that's a uro-oncologist who says that when a general urologist has reached the end of his ability, that's where I step in. I can give you more than what a general urologist can give you. He can take your prostate out, he can give you good continence, he can give you good erections. But what about your disease? What happens to your disease after that? That's when I step in. And that is something a general surgical MCH, surgical oncology, will not do, primarily because the amount of urology they get exposed to in their MS surgery is very limited. On the other hand, a Uro-Oncology Fellowship, which you do after an MCH in urology, clearly gives you a much better understanding of the disease that you're talking about. And then you go into the aspects of a disease that a urologist doesn't get in. He can take the prostate out very well. He can probably do it as well as a uro-oncologist can. But then that's not a uro-oncologist. And I think that's what the whole session has all been about. Where do you separate a urologist from a uro-oncologist?
Yeah, I think Dr. Jayan, Dr. Kulkarni, the thing which you were saying, we should discourage. I don't take any cancer surgeon in my department under me.
Before you move on to the next question,
sir.
I think it is very important to recognize the point which both me and Rajiv are trying to make, that it is not the whole time the emphasis somehow comes towards technique. Technique is a part, not the more important thing about oncology. It's the decision making, developing care. It's a lifelong commitment to the oncology patient. It does not mean a curative treatment. In fact, there is far more to it. So that is a discipline. Which uro-oncology is not a discipline of surgery or robotics. It's a discipline which will involve not only multidisciplinary treatment, developing palliative care, end-life support. All those things matter. We are not paying attention to it. And so, I personally feel that the current uro-oncologists who are practicing, they have far more responsibility. It is pretty disappointing to see sometimes that the so-called practicing uro-oncologists, their decision-making sometimes is sometimes very disappointing to see that things are getting done. That kind of things are not going to give you a good name. And the other person will say they are doing the same thing what is the difference? So the responsibility lies with the current people who raise the standard to such a manner that there should be a visible difference between what you do and what others do. I think that is very important.
Agreed, sir. Agreed, sir. And that is why actually if we have fellowship, it should be a structured program. But before, I hope that National Board will give us a fellowship in this country. And that is the job. I request Dr. Nitin and Rajiv. Dr. Ajay is not there. With that, I'll go for next question. And it is particularly for Yuvraj. Actually, I should have involved him in another question also. But then I selected this question. What struggle he faced in establishing practice? He did work as a, I don't know whether fellowship or not, but he was faculty in TMH, like JNK was there. But then I'll ask Yuvraj, because he came to a multi-specialty hospital, and what struggle he faced. Yuvraj.
Good evening, sir. I think it's a valid question in this situation. So the reason is that, so we think that, okay, we have done a Uro-Oncology Fellowship. And the next moment, if you ask the candidates, as of now, they think that they'll be welcomed with a garland in the public, in the society, even in the urological community. So that is not true. The thing is that Uro-Oncology, so we have done only 2 years of fellowship. And once they come out, what are the options and what the struggles they have? So the first thing they have to keep in mind is that it is a long process. It is not going to be overnight. The next day you are going to become a number 1 Uro-Oncologist. No. And the second thing is that, so now we don't have a designated Uro-Oncology units in teaching institutes because it is a teaching institute. In the private hospitals, they will ask 5 years of experience before joining any good private hospital. So we will be, fixed in between these two situations. So how to overcome this struggle, it's a very important scenario. So for me, it was not that difficult because, we worked I worked as a fellow in Tata Hospital for 2 years, and then I became a consultant. And then after, say, 8 years in Tata, then we moved to private. It was not difficult. But nowadays, to get a placement, so finally, once you do Uro-Oncology, we are looking for a placement. So that is the main struggle. So now, luckily, so many private hospitals are taking Uro-Oncologist. And my take-home message is for the students who finish Uro-Oncology fellowship, you work for 1 or 2 years in a center where Uro-Oncology setup is already there, and then establish yourself and then go for practice. Although it is a long process, there is a struggle, but in the end, so you will be the winner. That's what I would like to say.
Thank you, Yuvraj. I think you have mentioned 2 main points that it's a long process, and you have to find a place where you can have all the facility of a cancer treatment. Dr. Kulkarni, you want to add something on this? Because you moved from TMS to private, what challenges you faced? Dr. Kulkarni, is he there? He logged out. Okay.
Yes. No, I can. Hello, can I hear it? Can you hear me?
Yes, sir. Yes, sir.
Yeah. No, I spent 25 years and took up VRS and joined, teaching hospital, Bombay Hospital. Now I have got a plan for a Tier 2 and Tier 2, 3 cities. It's like, transplant team. One is a donor team and one is a recipient team. Now, what do I mean by that? Suppose if you are practicing in a Tier 2 city or Tier 3 city, 2 urologists can come together and share the practice. They also share everything, not only the losses, but also the benefits. Maybe sometimes as the team grows, it can have more people. So I think it has to be a time for group practice. Now, that's one area. There is another area which is like if you want to do a Uro-Oncology group, you can have one surgeon, you can have medical oncologist, and you can have another radiation oncologist if it is possible. So there are groups amongst urologists, groups amongst interdisciplinary things, and that can happen. So I think urologic oncologists can be percolated down to the Tier 2 and Tier 3 cities with this. And of course, metropolis or Tier 2 cities will have corporate hospital where they will get attachment. But if you have to go further down, it is possible. And that would be my take on this.
Yes, sir. That's a good idea. Only thing which I will say, who have logged in with us, is that you stick to your subspecialty. It will just take some time, but yes, it will come up very well if you stick to, if you are doing Uro-Oncology, just stick to it, just evolve in the surgical part, medical part, and all the knowledge of pertaining to even molecular or other things coming up, because this branch has changed like anything. I remember my time in 96 when I joined, it was open surgery. There was nothing in RCC. There was nothing for bladder. And then, so many things came after that. This is the question which Dr. N.P. Gupta asked me, and I said no. But I'll ask now Dr. Kulkarni, Dr. Nitin, and Dr. Ganesh. For Uro-Oncology Fellowship, is robot must? Dr. Kulkarni first, then Dr. Nitin.
Well, of course, it is not must at all. But today, it's going to happen in the next 5 years or so. Many, companies are coming with new robots. Say, for instance, CMR, Meditronics is coming, SS is coming. So I think the price will come down. and it will be available at much cheaper rate, and also the maintenance cost will go down. At this point, it may not be necessary, but slowly, you will be in a position to pitch into that. There should be no problem.
I think it has been answered very comprehensively throughout the seminar. Technology is an evolving process. Economy, affordability is an evolving process. I mean, tomorrow if somebody asks me, I will give you Mercedes-Benz free and a Maruti free, which will you drive? I will say Mercedes-Benz. Same thing. If you can get a robotic, yes. But is it a must for specialty? I don't think that is the true thing, because even if you look at the literature, that is not a single trial which has shown superiority of robotics as far as oncological outcomes are concerned. So I don't think it is important. It is a technique. Tomorrow something different may come. But I think it is not a must. We should rather place far more significance to the basic aspect of the uro-oncology training than focusing on robotics. So robotics is not a must, but yes, if somebody has it, wonderful, because it is definitely going to add to that specialty. There is no doubt about it.
Dr. Ganesh, any difference of opinion?
No, I think I agree with all of them. I think I just want to re-emphasize what Manohar said in one of his slides, that Uro-Oncology Fellowship is not equal to a robotic fellowship.
Yes, sir.
It was there very clear. So Uro-Oncology is a science. Robotic surgery is not a science. It's an art.
Sir, I made same comment, and Dr. Gupta called me back. He said, in 2021, I'm not asking 2000 when you joined Uro-Oncology. So I said, let me put this in the panel.
As Nitin said, if I'm given a Mercedes, I'll certainly drive it, man.
Yeah, correct.
If you ask me personally, I'd love to get my hands on a robot, but I know it's not possible. That's all. I'd love to learn that technique. So,
but having said that, sir, if suppose we are deciding for fellowship, so can this not be given to CMC, which do not have robot? I think we are all agreeing, if you don't have robot, that doesn't mean that you can't have fellowship. That's what I said, but probably there was some difference of opinion. Anyway.
Sir, can I tell one point?
Yes.
So yes. I think most of the uro-oncology fellowship centers where there are major uro-oncology work have robot. But having said that, the answer is perfect. That is, robot is not a must. But nowadays we should ask, is there open surgery is a must for uro-oncology fellowship?
That's right.
Because many people are going in a robotic way, and uro-oncology fellowship institutes are not doing open surgery is not a good thing. So I think open surgery exposure is a must and laparoscopy exposure is a must. They may not have done many cases, it doesn't matter, but they should know in a case when there is a trouble, they have to do open surgery. So that is
Can I
my
also
idea.
come in here, Dr. Raval?
Yeah, sure.
I have a difference of opinion here. And much as I agree with everybody that to do urology and to know urologic oncology, you don't need a robot. But to call yourself a uro-oncologist and not have experience of a robot, I do not think it's worthwhile today. It's like saying that you can do fellowship in endourology but not do PCNS. You don't have a PCN, you don't have a nephroscope, you do open surgery for stones, but you are an endourology fellow trained. So I agree 100% that every urology center does not need a robot, periodic. Every MCH DNB program does not need a robot, no doubt about it. But on the other hand, in 2021, to say that you are a uro-oncology 2-year trained fellow, but you've never touched a robot, I would be very unhappy with such a fellowship. And again, therefore, the context is very clear. I 100% again agree that it is a science. Uro-oncology is not a technology, it is not a technique, it is a science. But in order to practice that science and art in 2021, a robot is integral. And therefore, the analogy that I give again is to go back to saying that you have done an endourology fellowship for 2 years, but you've never touched a nephroscope because you take the stones out with open surgery. Nothing wrong with it. Probably 50% of stones around the world are still taken out by open surgery. But to say that you're a fellowship trained person in 2021 with a 2-year fellowship, but you've never touched that technology, difficult.
Dr. Nitin,
can I make a comment, Sudhir, on what Rajiv said?
Yes, sir. Yes, sir.
If we had a cheaper tool than the robot at the moment, I mean, you can't compare. You're comparing apples and oranges, Rajiv, here by saying that PCNL is a totally different thing altogether. You cannot. If the robot was a cheaper toy, a cheaper tool to do surgery, who would not love it? We'll all use it. So I think the problem is the cost. If the cost of this thing comes down, every department will have a technology, have a technique which will make life easier for him. At the moment, it is not the reality. So what, 21, we are 21, I don't know whether this reality will happen in the next 5 years. I sincerely hope it happens, but I don't think so.
I agree with you, sir, 100%. That means if Rajiv's point is correct, then if CMC is applying for a Uro-Oncology Fellowship, it will not be given. They do not have robot as on today.
No, that's an incorrect analogy. Analogy.
Then you tell me.
To do a fellowship, it doesn't mean that every single resource must be in-house. If we start assuming that is a mandatory requirement, half your programs will shut down.
That I agree.
Programs will shut down. So the two are not equally applicable.
No, here question was, Rajiv.
No. Let's be very clear. Yeah. To say that you do not need robotic experience or training, but yet be called a 2-year fellowship trained uro-oncologist in 2021, I disagree. To say that you must have that robot within your establishment to be able to impart uro-oncology fellowship training, I disagree with that too.
Okay. The question
two are
was
not the same. No. The two are not the same.
Yeah. Oh, okay, I got it. That you have to have experience of robotic.
That's fine.
If you go for fellowship in uro-oncology,
I think everybody
agrees on this.
Training in uro-oncology fellowship and have never seen or touched a robot in those 2 years. I don't accept that either.
So, sir.
Hey, when there are lots of training things which a particular center does not have,
yes, sir,
provide by rotation, but it does not mean that that's a mandatory thing. I think there's a difference between having a mandatory requirement and additional requirement. Well, so many centers don't do transplant. All India Institute of Sciences does not do kidney transplant and give MCH urology degree. So should they be disqualified? The answer is no. They can always send the candidates to the centers which do renal transplant to make an inclusive training. So I agree with that point that in today's world, one should provide an opportunity for the candidate who is registered for uro-oncology to have an exposure to robotic surgery. But it cannot be to train in uro-oncology.
I think there are two issues: recognizing one department and giving a training. These are the two issues. I think they need not be clubbed. If an institution doesn't have a robot, they can have facility to go to other place where it's available. And he can be trained back. So there should not be. We should not deny CMC the uro-oncology.
No, I just put this in that way, but then I think the things are clarified very nicely. So we go for last slide. And here, first question, probably they are both related. Who can start fellowship? What are the bare minimum requirements that are required to start fellowship? I think this has been told many times. Again, I can ask Rajiv and Dr. Nitin, is there any further you want to add on this thing? But I think everything has been told.
I think the National Board has discussed this in terms of fellowships. The last meeting that we had a discussion on fellowship. Okay. And everybody is very clear that it's going to be very difficult to find individual centers which can provide everything that a fellowship should have. This has been extensively discussed. However, the onus is upon that program to ensure that their trainees get exposure to everything. And if it means getting into collaboration with 4 centers, each center has a specialization in a particular field, and then they put together a program, that's fine. But to say my center only has this, I will run a fellowship, my students will not get this exposure, and so be it, you can't have that anymore. So that's the discussion that we've had, and I think, well, that's my viewpoint on it. It will be very difficult to find individual centers which have the volume loads to justify a really rounded fellowship. They will have to collaborate. And that's perfectly fine. That's how it has to be.
That's great. Sir, Dr. Nitin, any difference, anything you want to add on this?
What I said earlier, Sudhir, that this is a new specialty which is evolving. The responsibility of to make it a good subspecialty rests on the shoulders of who want to do this fellowship programs. You need together, all of you, make a program. Each one of you will have a strong point in something and a weak point in something. There should be a system for rotation of your fellows. So the end of the day, what are you trying to do? You are trying to get a good person, very well trained in all aspects of uro-oncology. It is not necessary that it can be done in one center. And when initially it will be far easier to do and kind of put a framework down so that people who are joining for the fellowship knows that they will get exposure to every, whether it's laparoscopy, whether it's robotic, whether it's a basic science, multidisciplinary meetings, because each one has a different setup. So I think that is what you people need to do together, to kind of sit down together, draw up a program which will be followed to the spirit, and then you will see after 5 years, your program will make a name. It need not be only Rajiv Gandhi's program. That is what I want to say.
Okay, sir. Thank you, sir. I'd like to have some opinion from Dr. JNK and last comment from Dr. Ganesh. And before that, I'll ask Dr. Kulkarni, would you like to add on this thing? What knowledge base is required?
What you said is absolutely right. These are optimum requirements for recognizing a department. You have to have radiation oncology and medical oncology and rotation. Now, what is deficient can be actually put into another place where it is available, maybe in the same city or maybe elsewhere. But I think these are absolute basic requirements, and you've got to encourage people to do research, and I think that's the best. And program should be minimum 2 years, not only 1 year.
Dr. Ganesh, final comment from you about uro-oncology as you keep on telling
I've always been one for subspecialization, and I think it's very clear that that's the need of the hour as far as I can see. It's happening. It's going to take some time. We were all in the category of jack of all trades and master of none. You see, so we don't count fellows like me in this category of you and Raghavan and Yuvaraja and all these guys. But times are going to change. And I think Uro-Oncology Fellowship is there. Nitin has made some very relevant points. And I think everything needs to be taken into view to get a good program, to get something that is solid, and that is going to be possible. I mean, don't think of something that's not going to work out. You've got to take something that's going to work out. And there is no doubt that it has to be. It may take 5-10 years, but start it somewhere. Your children might benefit from it. Thank you all to Raghavan and the entire SOGO team for this very nice program. Thank you very much.
Thank you, sir. Thank you, everyone. And it's a Saturday evening, but we are
there are one or two comments, Raval sir. One is a comment from NPG sir. It's quite a nice comment. Yes,
he's still there.
Sir, who will treat a patient of uro-oncology in a small town or village in India? Is what he has put. It's a very sarcastic comment. But what sir is trying to say is that if there are complicated uro-oncology patients, probably sir would want that patient to be treated in people who have expertise in the branch. And in that context, as Rajiv sir said, probably a good uro-oncology center will need a robot as well. Though it is not an essential, it is highly desirable as a criteria. If I use the right word for that. And another question Manal has posted, saying, is there a bare minimum number of cases that you feel a fellow should do per year in order to be good in the branch? What is the opinion of the panel? 50 pelvic oncology. Because UK, for a UK center to function as a uro-oncology center, the bare minimum is 50 pelvic oncology has to be done every year. So is there something that a fellowship program or a center should do in order to maintain the fellowship program? Is there any number that you think?
Can I just come in with an answer here?
Yes, sir.
I don't think anybody here in India has actually got a number that's based on data. The ideal data to look at would be to look at your learning curves for each surgery and see what is the bare minimum for each learning curve. But if the UK number for pelvic surgeries for a fellowship is 50, that is not very high at all. And I would certainly agree with that number, that if you aren't even seeing 50 pelvic oncology surgeries over a 2-year fellowship program, you probably don't deserve to be a fellowship program.
So, Manal,
I'm assuming you're talking about seeing, not doing. The fellow isn't doing the 50 surgeries himself.
No, so can I just come in? It used to be, it started off with 50 in 2002. Now for prostates, that's a minimum of 150 for a center.
Yeah.
And the idea is that you start with a smaller number and you gradually start centralizing the services. So if you have a minimum number, so for example, when we talk about a uro-oncologist, somebody who's done a fellowship, and if you set up lots of fellowships, a lot of fellows will come out And as Sudhir Raval sir was saying, that a lot of these people may not get jobs in centers. So if they are then working in in private practice or something, then they can act. If they're not doing a minimum number of cases, they could be sending their patients over to other surgeons who are doing it. But as a uro-oncologist, there is a diagnostic pathway for the patient, and then ultimately the patient has not, and that's not all patients, will have a complex operation. So if you can have a good setup where the patients are diagnosed and counseled correctly, then they can go to the high volume person or person doing a minimum number of cases for their surgery. So you could start with a low number for an individual surgeon, say at 10, and gradually build that number up. So people are not doing 1 or 2 cases a year, and that would certainly improve the quality of care that these patients are getting.
I think we do have a point, Manal, where you must be knowing India's situation here. And especially the making a structured program is great, but any center, when it evolves, it takes time, and there are like referral from physicians, surgeons, and general practitioners. But it's not that it is a hardcore system where you are referred to one place, and there are a lot of things they play in between. But then there is definitely genuine things are also going in the market. There are people who send the patient to cut places so that even they evolve there in practice also. I think, and as the things are evolving, many centers are doing the number of surgery which you said, especially for cystectomy may not be 150 prostatectomy in all the center, but they are doing quite a good number of prostatectomies, partial nephrectomies. Yeah. So whatever the program we have.
If you put in guidelines, but you
can I just make a comment on this?
Yeah.
See, I having worked in 25 years in an oncology setup, and then next 20 years into a teaching hospital setup, there is a distinct difference of the disease prevalence in oncology setup and the teaching hospital setup. So I think it's a complex situation. And in India, we don't have NHS, where it's difficult for this kind of things to that patient to be referred to somewhere else, in a metropolis or maybe in a smaller cities also. These are difficult things. Suffice it to say that 50 or some figure you arrive at, and you can put up this, but I would go along with Dr. Raval, what he said clearly, that let the center develop slowly, and as it graduates into a good center, it will take about 5 years for him, but that doesn't mean that he should be denied of that kind of things. So I think that's where we will be, because our systems are totally different. Practicing systems are different. They are not NHS.
Issue with us is the lack of centralization.
Which is why I was saying that if you have low numbers to begin with.
Yes. Issue with us is the lack of centralization. To establish a program for a site took more than 10 years.
Lack of referral program.
So that is the basic issue.
We do not have.
Unless we could centralize the patients, make a program, train program, this will not develop. Uro-oncology will not develop. So few people has to be committed for a long path where they can establish the program by gradually building the patients. Then only this will start.
Okay, good. Very good.
Thank you all.
Thank you, sir. Thank you all.
Thank you very much. We had a great meeting.
Thank you.
Thank you, Rajiv.
Thank you. Bye.
Thank you, Raghavan. Thank you, Raghavan.
Ganesh, thank you. Thank you.
We are going to...
Raghunath has to make
sorry.
concluding remark. Sorry.
Sorry.
Program is Raghunath has to make a concluding. Raghunath, please. Go ahead.
8:55 now. I request Dr. Raghavan to deliver a vote of thanks.
Thank you.
I discussed with Dr. Raghavan. It's too late. Let us not wait for that.
Before I do vote of thanks, Janvi has to project a slide about the forthcoming prostate cancer conclave. While she projects the slide, I'm just going to first and foremost start saying thanks to JNK sir and Raval sir for trusting me for this program. First and foremost to the SOGO core committee who said we should do this program. Thank you so much. My next thanks comes to the program directors, Manal, Mano sir and Ganesh Bakshi sir, who came along and exactly told what uro-oncology is about and what we expect from these fellows as well. And what I learned from this is that you need to have a proper attitude and an aptitude, a commitment to the specialty, not the technology. And that was made aptly clear so much by the program directors. We also heard from all the panelists about the struggles of establishing into the branch, the new people who are establishing in, and the struggles of already established people as well. I just highlighted the point that it is neither bed of roses or thorns, just to say that we have a good mixture of fun as well as commitment, and anybody who is willing to take that will be part of this club of uro-oncologists. As Rajiv sir at the final panel discussion so nicely said, it is Ganesh sir nicely put it, this is the future, it's going to happen. It is up to us to shape the future. We as a committee, we as a bunch of people have to make sure the future is shaped in a proper way so that the future uro-oncology trainees are given that right opportunity and tool and the guidance that it will become something that will be the future for them as well. So with that remarks, I would like to say thanks to all of you and thanks to Ferig for supporting this as well. I really appreciate the time and effort by all. Thank you so very much, sir.
Thank you all. Good night.
Bye.
Good